each other, but we can just spare a few minutes in introducing to complete the formality. Is that fine?
Yes, ma'am. Ma'am, as you said, can we have Nagaraj to have a very short run of the program? 30
Yeah,
seconds run of the program.
yeah, sure.
Of November. Okay, sir. You just put me a message, that is enough.
Right.
Okay.
Mr. Nagshankar, would you like to talk now? The introduction?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. I'll start.
Check பண்ணிட்டு போட்டுட்டேன்.
I think
I'll talk and start, ma'am.
yeah, kindly I request everybody to put your mobile phone in the silent mode. Okay, right. Get ready with the chairperson.
Open பண்ணுங்க சார் இது.
Nagshankar, basically.
Greetings from Forts. We welcome all the participants to this webinar on UTI in women, myths and mysteries, an interesting topic. We thank Urogynecology and Reconstructive Pelvic Surgery Society of India under the leadership of Professor N. Rajamaheshwari for giving us an opportunity for conducting this webinar along with 27 chairpersons and speakers across India and its subcontinents. About Forts. Forts is in the pharma industry for the past 43 years, following the motto of innovating for good health. We from Forts have innovative products in UTI and stone management like KMAC, KMAC B6 active and KMAC UTI with potassium advantage. At present, we are exporting our products to over 50 countries around the world. We welcome President of URPSSI, N. Rajamaheshwari ma'am, the Professor Emeritus of Urogynecology. She is the first gynecologist to qualify in urology in India and established urogynecology specialty in India. Professor N. Rajamaheshwari is the editorial board member of International Journal of Urogynecology and the Obstetric and Gynecology, United Kingdom. Moreover, Professor N. Rajamaheshwari is the member of International Advisory Board of International Urogynecology Association, IUGA, representing Southern Asia. We also welcome today's session one chairpersons, Professor Arun Chawla from Manipal, Dr. Chengalvarayan from Chennai, Dr. Neeta Thakre from Ahmedabad, Professor Saiba Akhtar from Bangladesh, Professor Shah Gufta Tahir from Pakistan, and Professor Poonam Mathur, Indore. With this short introduction, I hand over the session to URPSSI and Rajamaheshwari ma'am for further proceedings. Thank you.
CV chair.
Open பண்ணுங்க. Hold up. Click. Chairperson 1 2.
Hello.
Yes, ma'am.
Okay, do you have the slide? Do you have the slide? Hello?
Slide of whom?
I'm sharing my slide. Do you have have the Yes, Nagashankar?
Yes, ma'am. I'm able to see, ma'am.
Your session 1. So we have good afternoon, everybody. Welcome to the webinar on UTI in women. And we have divided into, am I audible?
Yes, ma'am, audible.
Okay, right. So we have divided this into 2 sessions, session 1 and session 2. In session 1, it will be UTI in women, and it will be chaired by Professor Arun Chawla, Professor of Urology from Manipal Kasturba Medical College, and Neeta Thakre from Urogynecology from Ahmedabad, and Chengal Ryan. He is the leading urologist from Madras Medical College with an excellent academic background. And then Professor Saiba Akhtar. And she is well known for her fistula work, and she has committed her entire life to the fistula relief work. And she is a former president of OBGY Society of Bangladesh. And she is a member of many national and international associations. She is also a member of FIGO Fistula Committee, an expert advisory board. We also have Professor Shafta Tahir, who is the current General Secretary, Pakistan Urogynecology Association. She is also currently the professor and head of the Department of Teaching Institute at Shaiwal Medical College, Pakistan. And we have Poonam Mathur, a renowned OBGYN gynecologist and obstetrician from Indore. She was from the Indore Medical College, and she has an excellent academic and teaching and surgical expertise. It is well known to known to everybody. Each and every one of you know each other, but still, and I just managed to say a few words. With this, I'll hand this over to the chairpersons. I think Professor Arun, is Arun Chawla there? Stop. Hello? Hello?
Yes, ma'am. Yes, ma'am.
Is Professor Arun Chawla there?
Arun Chawla, sir.
If it is not, Changal Ryan, please take over.
Yeah.
Thank you very much, ma'am.
Yeah, take over, Changal Ryan.
It's really a privilege for me to get this opportunity, ma'am. I have seen ma'am work like anything. It's not somebody gets by luck and gets into a position. I have been in personal touch with ma'am for all these years. I know the amount of hard work madam has put in this conference and everything and everywhere. And it is my privilege to introduce Professor Gauri Durayarajan from Puducherry to come up for a first presentation, please.
Yeah, visible, ma'am, your slide. Yeah.
Thank you very much. At the outset, I would like to thank Rajeshwari Maheshwari Madam for this opportunity. Urinary tract infections are the most common infections in women worldwide, with a lifetime incidence of 50 to 60% in adult women. It's a huge clinical and socioeconomic burden and can cause significant psychological distress. It could involve the upper urinary tract or the lower urinary tract. It could be a simple, uncomplicated one or go on to become a complicated one. Women are more prone, probably because of the short, straight course of the urethra and its proximity to the anus and the vagina. It can get precipitated by sexual activity and gets worsened because of vulvovaginal atrophy that sets in at menopause. As we all know, the tri-layered bladder mucosa, the innermost superficial layer, is layered by a hydrophilic glycosaminoglycan or the GAG layer, which attracts a lot of water. A well-hydrated bladder mucosa is important because it protects against bacterial adherence. This condition needs a swift assessment and diagnosis. Is clinical diagnosis and urine analysis enough? What about patients on catheter? What about further workup? When to do? Prompt treatment, we all understand, is essential to prevent ascending infection and to prevent systemic infection. Antibiotics is the mainstay, but which antibiotics to start with as empirical? And antibiotics is only tip of the iceberg. There's a whole gamut of alternate treatment. Treatment is not enough. We need to have strategies to prevent recurrent UTI. With improved understanding of the etiology, the strategies to prevent recurrent UTI has been evolving, and now we are at the threshold of vaccination against E. coli. So today, we will learn about all this in the next 1 hour in this webinar session under the following heads. So let us unravel the myths and mysteries of this misery. Thank you.
So, thank you, Dr. Gauri, for that introduction. Now, the next speaker is Dr. Ankur Mittal, who is from Rishikesh, and he is an associate professor and head of the urology at AIIMS Rishikesh. And he is also head of robotic division of AIIMS Urology. And he is the program director of female pelvic medicine and is conducting PDCC course as well. I welcome you, Dr. Ankur Mittal, and he is going to speak about prevalence of UTI in women.
Thank you, ma'am.
Yes, sir.
Are my slides visible, ma'am?
Yes.
Yes, sir.
Thank you so much. So at the outset, I would like to thank Dr. Rajmaheshwari, ma'am, and for giving me opportunity to talk on prevalence of UTI in women. In next 3 minutes, we'll be covering after a very good introduction by Dr. Gauri, ma'am. So let us see what is the prevalence in United States. It is 25 to 40% of women like 20 to 40 years of age, they have UTI. So the peak rate is around 18 to 39 years. And we can say that 0.5 episode per person per year. But what about in India? So we have an article in International Journal of Community Medicine and Public Health. They have studied 250 patients of reproductive age group, And they have seen the prevalence of UTI among female reproductive group was around 20.4%, which is almost as equal as what has been documented in US. So UTI, so the incidence is increasing with age. So there is an abrupt increase if we see that in reproductive age group, but then there's a steady increase as the age increases. 5 to 14 years, 1% of girl will have bacteria. 15 to 24, 4%, 1 to 2% added per decade. By 24 years, by and large, 30% women will have symptomatic UTI. So if we see in totality, like 50% of women will have a UTI during their lifetime. So it is important. So what else? Like prevalence of UTI, what happens in pregnancy? In pregnancy, the prevalence and rate of recurrent infection are same as in non-pregnant women. So the prognosis, the course, the treatment modalities differ. So like asymptomatic bacteria is 2 to 7% in pregnant females. So if we talk about prevalence of what is frequency of healthcare associated UTI, so it is 12.9% as documented in United States by a study in Global Epidemiology UTI published in Current Opinion, and it is almost as double as 24% in developing countries in India. Once a woman gets a UTI, so it is said that 27% of these women will have a confirmed recurrence within next 6 months. 2.7% have a second recurrence within the same period of time. So it is really important to diagnose and treat them adequately. Whatever figures we have just discussed about the prevalence of UTI globally or in India, these figures doesn't give us an accurate definition or identification or incidence prevalence of UTI, because it is difficult to accurately identify these, as it is not a mandate infection which need to be notified in US and other countries. So dear friends, this is again, I can say, tip of iceberg, important issue to be discussed today. And definitely we will have a great session ahead regarding the UTI and its treatment. Thank you for your patience here.
Slide share. First.
Thank you very much, Professor Ankur, sir. Now the person who is coming up to present actually doesn't require any big introduction, because the person who is going to present now is none other than a person who started the Department of Urogynecology in India. The first woman urologist in India who was a gynecologist who turned as a urologist. She is the educational committee member, active member of the IUGA, and presently the president of URPSSI. May I request Professor Rajamaheshwari ma'am to kindly come forward for a presentation, please.
Thank you, Chengal Ryan. Good afternoon. I thank everybody. That was an excellent presentation by Professor Gauri and Professor Ankur Mittal. With this, let me start with a very simple step, that is the urine analysis. Let's look at the 3-step urine analysis. So mainly it involves the microscopic analysis and the chemical analysis of the urine. So we all know it is the clean catch midstream voided sample, and it has to be processed. The sample should be processed within 2 hours. If not, it should be refrigerated and used within 24 hours. So we have the gamut of tests. So we can assess the physical properties like specific gravity, pH, and chemical analysis. All these can be accomplished with the conventional lab investigations and also with urine dipstick test. Let us start with the specific gravity. The specific gravity is important in UTI in the sense with pyelonephritis, it will be low. So that is one of the function of the kidney, which will get a very sensitive function, which will be lost, and the first to be lost. So then next one is the pH. We all know that normal urine is slightly acidic, between 6 to 6.5. If a person has a high pH or an alkaline pH, it means either she has infection or predisposed to infection, or she has true white stone. So ladies and gentlemen, if you look at this slide, there are certain organisms.
Excuse me, madam.
Hello?
Cannot see your
slide has to be shared, ma'am. Slide has to be shared.
Till now, it is not shared, is it?
Yes,
No,
ma'am.
ma'am. No, ma'am.
No.
No, ma'am. No, ma'am.
No?
No, ma'am.
Why didn't you say,
No.
please? Oh, hello?
No slide.
Please,
Yeah, it's not
please tell us.
visible.
I'm under
It's
the
not
impression.
being shared, your presentation.
It's not.
Oh. I'm sorry. They have clicked on the slide share. Do you see that?
Now visible, ma'am. Now.
Oh.
Yes, now it is visible, ma'am.
Please. Should I? So can you see it now?
Yes, ma'am. Yes,
Please intervene if you're not able to see
yes,
it.
ma'am. Yes.
Yeah, very well.
What we see is the 3-step urine analysis, okay? The macroscopic, microscopic examination and chemical analysis. So this is the clean catch midstream specimen sample collected, should be processed within 2 hours or should be refrigerated and processed. So we have the a facility to check the physical properties like specific gravity, pH. We have the chemical analysis, and both can be done with the conventional urine test as well as with the urine dipstick. So specific gravity will be low in the presence of pyelonephritis, which you can very easily check even with the dipstick test. And the next important thing is a pH, with normal urine is slightly acidic between 6 and 6.5. So if the person has a high pH, either it shows the person has infection or predisposed to infection or has struvite stone. Do you still have the slides? Do you have the picture?
Yeah.
Hello?
Yes, ma'am.
Yes, ma'am.
Okay.
Yes, ma'am. Yes,
Okay.
ma'am. Visible.
So now there are certain organisms which thrive in acid urine, like E. coli. There are certain organisms like the urea splitting organism, Proteus, Pseudomonas, which thrive in the alkaline urine. So it is very important for us to know the pH. And it is also true that some of the antibiotics work effectively under alkaline pH, like say aminoglycoside, quinolones and all. There are certain antibiotics which work effectively in acidic in nitrofurantoin and methenamine and all. So at times, if the response is not adequate, one need to adjust the pH to optimize our effect. So all of us know from our grandma days, then will say immediately if you have cystitis, if you have a suspected of UTI, they'll say you take citralca. But is it right? Should we go on be prescribing citralca to our patients? Are we justified in doing it? No, because citralca may increase the pH, but it has a lot of disadvantages, like it may cause sodium overload. So in a hypertensive patient, you cannot give it. It increases the calcium excretion. So in the long run, it may affect the bone, it may cause bone loss. And if you combine it with the quinolone group, then the patient can develop tachycardia. So what one should do is, if you want to alkalize the urine, one should resort to potassium alkalizer because it avoids sodium overload, reduces calcium excretion, and it is quite safe to be used with quinolone group of antibiotics. Next is the chemical analysis. We have protein, glucose, so many chemicals to be checked. The most important is the proteinuria. If with a dipstick, you can check it, or even with a heat coagulation test, you can check it. Immediate instant result can be obtained with a dipstick. And it is, in severe urinary tract infection, the proteinuria will be significant. And then we have the important test, what is called the nitrite and the leukocyte esterase detection. See, the leukocyte esterase test is a very sensitive test. It detects the associated pyuria in UTI, whereas nitrate is an indirect test and it detects the bacteriuria in the sample. So there are organisms like E. coli, Klebsiella, protease, they convert nitrate into nitrite, whereas there are organisms like Pseudomonas, enterococci, which they don't. So if nitrate is positive, it is possible that the sample has any one of these E. coli, Klebsiella, or protease organisms. So if leukocyte esterase is positive, it would mean that there are more than 6 WBCs per hypophil. If leukocyte esterase is negative, if nitrate is negative, then it is possible that the urine is sterile. So this is the US FDA approval and showing you how leukocyte esterase can be detected instantly and which is approved. Similarly, the nitrite. It is an instant in the office, you can use it as a screening tool, and instead of waiting for 48 hours for the culture to come, you can just make sure whether the patient has infection or not. And then it is reported that if both tests are positive, nitrite and leukocyte esterase, then it is likely to be more accurate to diagnose urinary infection. So what are the other indicators for UTI? So you have the hematuria, either macroscopic or microscopic, or if you take the centrifuge sample and examine under microscope, detecting the RBCs, WBCs, bacteriuria. These are all the next important things. So the dipstick test has the disadvantage that it can't be done with a dipstick, but you can get it done only with the conventional laboratory test, which is considered as the gold standard test. So the dipstick is likely to be only a screening tool. So in the microscopic examination of the urine sediment, there are likely to be normal and abnormal cellular elements like WBC, RBCs, and whatever it is. We'll go through it one by one. So if there is bacteria in the urine, you call it as a bacteriuria. If there is bacteria and white cell, then it indicates it is urinary infection. So what is significant bacteriuria? 10 to the power of 5 uropathogen, same organism collected in the midstream voided clean catch sample. But at times, even with low count, if there is associated pyuria, for example, the count may be only 100 or 10,000. But if there is a pyuria, say more than 2 WBC in centrifuge sample, or more than 10 WBC in a hemocytometer, or growth of even a single organism in a suprapubic aspirated sample, then it means significant bacteriuria. So how probable is the infection? So even a single gram-negative, gram-positive cocci or bacilli from suprapubically aspirated sample, the probability is 99%. So catheterized samples, 10 to the power of 4 to 10 to the power of 5. In clean voided midstream sample, it is better to stick along to the 10 to the power of 5 organisms. So ladies and gentlemen, there is one more thing available, that is what is called the asymptomatic bacteria. 10 to the power of 5 organisms per ml, 2 consecutively collected samples within 24 hours gap, similar organism, and then if there are no symptoms, you call it as asymptomatic bacteriuria. So what is the significance of number of colony types and the significance? If there are more than 3 organisms, colonies you see, then I think you should ignore it. If it is 1 or 2 and 10 to the power of 5, you should proceed to grow the organism to do the sensitivity and other things. And if it is 1 or 2 with only 100 colony forming units, then you need to clinically correlate and use your discretion. So in the microscopy, you have so many things, WBC, RBC, and other things. We normally see WBC in urine. Normally, yes, there can be less than 5. Do you normally see RBCs? Yes, that can be less than 3. But normally you don't see any bacteria, yeast, or parasite. Do you see any cast? No. Do you see any crystals? Only few. So do you see any epithelial cells or squamous cells? No. So all these things one should consider. So what are the abnormal findings? So if there are more than 3 RBCs, more than 5 WBCs, more than 2 renal tubular cells, more than 10 bacteria per hyper field, then it becomes abnormal results and you need to plan your treatment accordingly. Ladies and gentlemen, and we know that hematuria, macro or microscopic. If there are more than 5 intact RBCs per hyper field, you classify it as hematuria. So hematuria indicates infection. So if it is macroscopic, you may not need any elaborate thing, but if it is microscopic, unless you do a microscopic evaluation, you will not be able to detect for various etiological factors as shown here can give rise to microscopic hematuria. Often people think that if it is microscopic hematuria means it is a micro problem. Well, it is not so, because it has the same significance as that of the microscopic hematuria. So a patient should be thoroughly evaluated if you encounter microscopic hematuria. So what about the sediments? In the sediments, look at the RBCs, they appear like hourglass. So normally 1 or 2 RBCs per high power file can be seen. If you look at the WBCs, they are spherical, appear single or in clumps. If it is in clumps, it is a urinary tract infection. What about the sensitivity specificity? Here is a test. Leukocyte esterate is a highly sensitive but a low specificity test. Similarly, the nitrite test is a highly specific with low sensitivity. But if you take the WBCs, if at any time, if it is significant WBCs are there, it is a highly specific, highly sensitive test. Similarly, bacteria, it is highly specific. The RBCs has a high specificity. The pH has a low specificity. So many things. Similarly, the crystals. There are few crystals can be seen under microscope, but if it's in a huge amount, one should suspect the possibility of stone. So the yeast and other things normally not seen. If you see them, it indicates the infection. So ladies and gentlemen, this test, the urine test, which is a simple test, effective test, confirms urinary infection and guides the clinician. And dipstick is a good screening tool. And microscopic and chemical analysis of urine is invaluable. And do remember that management of uncomplicated UTI, even without imaging studies, higher imaging evaluation can be done based on the urine test alone. And in complicated cases, one is forced to do for the higher evaluation, CT, MRI, all those things other than the basic evaluation. But still, no one can afford to skip this simple urine test. So the value of urine test should not be underestimated, and there is no substitute for a simple urine test, which you can say it as a ready reckoner of the urinary infection and many other diseases in human being. So this is the first part is over. The next I will move over to the types of UTI and the clinical presentation. So with the permission of the chair, hello.
Please, yes,
Can I go ahead?
Yeah,
please
madam,
go
sure.
ahead, please go
Okay.
ahead.
So next is types of urinary infection. So what is urinary infection? We all know it is the establishment and multiplication of microorganism which induces the inflammatory response in the urothelium. So what are the different types of urinary infection? You have the classification acute, chronic. You have the anatomical cystitis, urethritis, pyelonephritis. It can be symptomatic, asymptomatic. It can be uncomplicated, potential for complication, or complicated, or maybe at extremes of age in children or in a geriatric age group like that. There are special infections like COTI, that is a catheter-associated infection, which Professor Gauri pointed out. There can be urolithiasis associated, particularly the diabetes, candidal, emphysematous, postmenopausal, postcoital, pregnancy. We have a separate session. And similar, there are so many different types like neurogenic factors or following operations, or with a full-blown systemic manifestations like urosepsis. Well, what is an accepted classification? What is that we can clinically adopt is either uncomplicated or complicated. Uncomplicated means infection in a normal urinary tract. Complicated means infection in an abnormal urinary tract. Please do remember that both uncomplicated and complicated can feature as cystitis, pyelonephritis, or as recurrent urinary tract infection. What is the organism which is usually bothering us is the E. coli, 75 to 85%. And the staph saprophyticus, 5 to 10%. The others are much less. So if you look at this slide, if you look, mostly it is the E. coli, but in the complicated group, other than E. coli, you can see the Enterococcus, Candidial, and Klebsiella, which are recognized in the complicated infections. There can be ascending, you have to swiftly diagnose the acute UTI. Otherwise, it can ascend and can have a systemic spread and become a full-blown thing. So this is a very good picture which I took it from the net, which shows how very easily the organisms ascend. They migrate from the perivaginal, perianal area, ascend through the urethra to the bladder, and sometimes in the presence of catheters, they form the biofilm, and from that they can very easily ascend and become the pyelonephritis and other things. So first let us talk about the acute uncomplicated cystitis, which is very common, and E. coli is the culprit most of the times. So we all know the lower urinary tract symptoms, dysuria, urgency, frequency, pain, strangury, all those things. And it is said that you can even manage without even urine culture. But there are situations like when a patient presents with atypical symptoms of acute uncomplicated cystitis, or if you suspect pyelonephritis, or if the symptoms does not resolve within the treatment stipulated, then you need to proceed further and evaluate her thoroughly with culture and everything. Then is the pyelonephritis. As Professor Ankur Mittal said, the pyelonephritis is much higher in women compared to men. And particularly it is higher in diabetic patients and in other risk factors, which I will be showing you soon. So very typical, all the systemic features, flank pain, costovertebral tenderness, high fever, chills, all those will be very typical. And in a patient with septic shock, I needn't have to tell you what the manifestations would be. So you need to go in, but even a count of 10 to the power of 4 becomes significant in pyelonephritis. So methodically, we need to evaluate the patient with basic lab test as well as higher evaluation. And then we also have asymptomatic bacteriuria. We know that it is 10 to the power of 5, and it is significant bacteriuria without any symptoms. The prevalence also varies. In elderly women, it increases. In pregnancy, it is high. There is a separate session. So I'm not going to deal with it. One point I would like to point out is that there is based on evidence, there is a grade C recommendation to say that there is no need for the clinicians to subject your patient for surveillance of urine test and urine culture for asymptomatic bacteriuria in non-pregnant patients. So clinician should not treat asymptomatic bacteriuria because it is grade B recommendation in a non-pregnant woman, because it can even protect against the superinfecting symptomatic UTI. So the message is that you need to screen and treat asymptomatic bacteria in pregnant women and in patients who will be subjected for urological evaluation or transplant patients. And there are also patients who are symptomatic with low count. 30% of symptomatic women can have a lower count, but we tend not to treat, but it is worth remembering that even this low count can cause chronic damage to the urethra. So what is recurrent urinary infection? So recurrent infection is 2 separate cultures proven within 6 months or 3 episodes within 1 year of cystitis with symptoms. So do remember that recurrence also can occur in the uncomplicated as well as in complicated types. So you can, if there is a repeated pyelonephritis, one should think of the complicated kind of infection. So what is recurrent UTI? There should be antecedent infection which is documented, successfully resolved, and then recurring. So types of recurrence can be either reinfection or bacterial persistence. What is reinfection, which is very, very common, 95%, and it occurs at longer intervals, and each time you get a new organism. The origin is from outside the urinary tract, whereas the bacterial persistent is only 5%. It occurs at shorter interval with identical organism originates within the urinary tract of the person. So the reinfections patient may not require an elaborate evaluation. On the contrary, patients with bacterial persistence will need a thorough and a meticulous evaluation to plan the treatment. So there is a narrow line between unresolved infection and bacterial persistence, because in unresolved infection, it is treatment attempted and fail to eradicate the infection, which usually happens in persistent resistance, non-compliance, or in Staghorn stone. Whereas in bacterial persistence, you successfully treat and then it recurs. That is the difference. The risk factors, most of us know, being a female is a risk, and renal tract anomalies, everything. And one genetic factor which I thought should be worth remembering is the P1 blood group. This 97% of the young women with recurrent pyelonephritis, they are positive for the P1 blood group. And similarly, there are different host characteristics, behavior, and bacterial virulence which influence the course of the infection and the type of infection, the clinical manifestations, and treatment. Particularly in the postmenopausal women, it is the estrogen deficiency. So there are so many risk factors. As we go, we will discuss each and everything. So similarly, in the complicated infection, catheterization, diabetes, and the emptying problem, neurogenic bladders, all those things form the risk factors. One important thing I would like to share with you is this pH of a high, or otherwise called alkaline pH, and its relationship to the urea splitting infection. The organisms like this Proteus, Klebsiella, Staphylococcus, Pseudomonas, all these infections, they are urea splitting organisms. They produce urease enzyme, which converts urea into carbon dioxide and ammonia, which raises the pH, which causes the precipitation of the magnesium ammonium phosphate and forms stone. And moreover, this ammonia causes damage to the glycosaminoglycan layer, promotes bacterial adherence, and enhances the formation of stone crystals. So that is the importance of knowing about the urea splitting organism to plan the treatment. And there are certain special infections like emphysematous cystitis. I'm not sure how many of us in day practice encounter emphysematous cystitis. Definitely those who are in the teaching institution will see it. The first and most important diagnostic clue is the presence of gas around the bladder. Women are more commonly affected, and the common organism is either E. coli or enterococci. Particularly, you can see in diabetes, women with indwelling catheter, or those who are on immunosuppressive drugs. And clinical features will be, there will be a range, like irritative symptoms, abdominal discomfort, hematuria, etc. But pneumaturia, because some of our patients say they pass some gas in the urine, it's a specific, but it is not frequently complained. So CT is the best evaluation. Either you can see the gas level or you can see the gas around the bladder like this. So the treatment is usually you treat it with a ESBL kind of infection, like with antibiotics, and some 10% may require even intervention. Next is urinary tract candidiasis, particularly common in catheterized women and in diabetics. It's very common and in the hospitalized population. So mostly asymptomatic, but colonize over the catheter and colonize over the bladder. And it can cause even a severe kidney damage. And the risk factors are elderly, diabetes, catheter, and all the devices like patients in ICU, parental nutrition, all those, any device can cause the candidiasis. The symptoms may be cystitis, pyelonephritis, or you can even see a fungal ball in the bladder. And if there is candidemia, you will have the systemic symptoms also. So ladies and gentlemen, candiduria is defined more than 1,000 colony forming units per ml of yeast from 2 cultures. And how do we treat them? If she is asymptomatic, no treatment. If she is symptomatic, remove the catheter first. Still there is no response, resort to fluconazole treatment. Sometimes you may require even bladder irrigation with amphotericin. And candida will clear. Candida clears, but it will reappear. Similarly, if there is a fungal ball, as shown here, you may have to surgically remove it and then start her on fluconazole. So that sometimes there can be renal candidiasis, and you may need an antifungal irrigation of the pelvis or amphotericin parenteral injection also. So next is the most important thing, that is the catheter associated urinary infection. They fondly call it as CARTI. CARTI is very common if you use either indwelling or suprapubic or even intermittent catheterization. 10 to the power of 3 colony forming units is enough to call it as CARTI. And even if you remove the catheter within 48 hours, still if she continued to have the symptoms with no other source of infection elsewhere, it comes under CARTI. CAR-T is about 40% of all acquired infection and 80% of the hospital acquired infection. So if you see that the longer you have the indwelling catheter, the higher are the chances of catheter associated infection. So there is factors, as you know, diabetes, all the immunocompromised situation. First, there is a biofilm formation on the device. And that is the primary mechanism. And then that proceeds on to the CAR-T. The CAR-T, it is usually the E. coli and the Candida. So this is the picture showing you how the infection can occur here at the external meatus, at the joint where the catheter meets the catheter, and then where the urine is drains through the outlet. So what is the treatment? If asymptomatic, no treatment, or else you can remove the catheter. If there is secondary infection, brief course of antibiotic. So what is caution? To avoid CAR-T, you need to use a closed system. Whenever you insert a catheter, use aseptic mechanism. You tie the catheter bag at a lower level without any obstruction and dependent drainage with no loops or a block. That is the important thing. Ladies and gentlemen, I would like to conclude by saying the urinary infection is a spectrum of symptoms, signs, and manifestations, right from asymptomatic bacteriuria involving lower tract, upper tract, with so many symptoms and manifestation as shown. So acute UTI needs swift assessment. Otherwise, it can ascend and spread into a systemic infection. So recurrent urinary infection demands elaborate evaluation. And pyelonephritis demands an aggressive treatment. If a patient has complicated UTI and secondary structural maldevelopment or obstruction, or if there is any urolithiasis, one should address all these things initially. And beware of the emphysematous urinary infection, candidal infection, and CAR-T. Ladies and gentlemen, if with all this, I would like to remind you that urine analysis are a ready reckoner in UTI, and it is a simple test, but crucial, and we can't afford to skip it. Thank you very much.
Thank you, madam. That was an excellent presentation.
Thank you, Raji.
Thank you, madam.
Hi, Raji. How are you?
Oh, fine, madam. Thank you. Welcome. Welcome.
It was a very nice
you.
presentation and very nicely covered the simple test, but very nicely interpretation and everything you have covered. It's really a wonderful presentation, madam. Thank you.
Okay.
Thank you very much for that excellent presentation, madam. It was especially the CAR-T and the candidal infection were a fantastic highlight in your presentation.
Yeah, actually.
Can we go to the next speaker? Yes, ma'am, please.
Yeah, as urologists, And we are forced to use catheters more in our day-to-day practice. And we encounter this special infections more frequently than anyone else. I thought that it may be worth bringing it to the attention of everybody.
Sure. And
Th-
most people
thank
treat the urinary tract
Uh,
infection part rather than the cauti part, exactly.
yeah,
Yeah,
correct.
certainly.
Okay,
Excellent.
I, Raji, I like to thank you for really inviting me. And also, it was an excellent presentation. You didn't leave anything regarding urinary tract infections, starting from the very simple to complicated. I think it is really a good source of learning for the participants, even including the chairpersons here. Thank you so much, Raji.
Thank you, madam. I think the chairperson can request
Yes,
Professor
ma'am.
Hemant Goyal.
Exactly, ma'am. Yes, ma'am, please.
I would like to invite Dr. Hemant Goyal
Stop it.
for his talk on antimicrobial treatment. Can you please share Dr. Hemant Goyal's slide? Dr. Hemant Goyal, please, can you share your introductory slide? Am I audible?
Yeah,
Yes,
audible,
you
ma'am.
are.
Yeah, audible, yeah.
Hello, Hemant.
Yeah, ma'am, I'm doing.
Yeah, okay. Take your time, no problem.
As Dr. Hemant is trying to coming up with a slide, it's a very important topic which Dr. Hemant is going to deal with, the
Yes.
antimicrobial management. This is something which most of us are always dilly-dally and confused. Which antibiotic to start first and how to proceed, how long. I think Hemant, the young urogynecologist, upcoming, already a professor, should be a very nice person to share his slides with us.
There's some problem in my sharing. I don't know. Can we have a second person having lecture? I'll take after this. There's some problem in sharing.
It is possible. So if we can find out, maybe, madam, if you're ready with the next lecture,
I'm ready. I can do it, and Hemant can get ready. Meanwhile,
exactly. Yeah.
So, ma'am will speak on antimicrobial treatment.
Yeah.
Yeah.
Not.
Second.
They're saying it, but I say that.
Yes. Now.
Do you have the?
It's being shared. Yes.
Yeah, visible, ma'am. Visible.
Yeah.
Visible. Okay. Okay. Meanwhile, when Hemant is getting ready, let me talk about the non-microbials. You will be knowing Hemant is a very important person. He is going to tell us about the most important part of the UTI treatment, that is antibiotics. Okay. Now, non-microbials. So we know that each and every person will prescribe something for a urinary infection. Right from the grandmother, from the next door neighbor to everybody. They'll say, somebody will say, take the Chinese herbal medicine. Somebody will say, take cranberry. And someone say, use the estrogens, like so on, so forth. So many things are there. So what about this Chinese herbal medicine? So many things are available, but still the mechanism action is unclear, and there is no robust data available for this Chinese herbal medicine. And next is methenamine is a very good drug. I don't know how many of you still recall our experience of using the mandelamine. It is used to be called as mandelamine, methenamine. It is a weak base, hydrolyzes urine, forms ammonia and formaldehyde, which kills the antimicrobials. It is neither bactericidal nor bacteriostatic. It is effective in acid pH, and none of the organisms develop any resistance. And what about the role of cranberries? Cranberries, it is said that it aggregates on the pili of the surface of the bacteria, reduces the attachment of the bacteria to the urothelium. So subsequently, the bacteria gets clumped and excreted. So cranberry, does it cause acidification? No. Is it bacteriostatic? No. It only in vitro, it shows bacterial adherence to uroepithelial cells can be diminished. So there is no evidence, no statistically significant benefit with the usage of cranberries or cranberry juice. So the NICE and the RCOG guidelines are against the use of cranberry in the management of urinary tract infection. What about D-mannose? D-mannose is a sugar derivative of cranberry. The initial results are quite encouraging, D-mannose. There are studies, RCTs, which have compared the role of D-mannose with antibiotic nitrofurantoin. And the results are good. But NICE has recommended use of D-mannose as self-care treatment in non-pregnant women, not in the pregnant women. What about lactobacilli, which is normally present in our intestines? And when lactobacilli, I encounter some disturbance, Mr. Nagashankar, please.
Yes, ma'am. We'll unmute
Yeah,
others.
okay.
I'll unmute others.
So normally when you compare use of lactobacilli with antibiotics, definitely antibiotic is superior to lactobacilli. But please remember, lactobacilli will will create an acidic environment which is hostile to the microorganisms. So, and also the lactobacilli produces antibacterial substances like hydrogen peroxide and bacteriocin, which will diminish the addition of the uropathogen to the uroepithelium and eliminates the bacteria. But the robust data are needed to support the usage of lactobacillus with evidence. What about the estrogen? We all know that in postmenopausal women, estrogen level goes down, lactobacilli level goes down, uropathogens thrive, increase, the pH becomes alkalotic, and the risk of infection is higher. When you supplement with a topical vaginal estrogen, the lactobacilli level enhances, the pH becomes acidic, and the E. coli colonization becomes less. So we all have estrogen receptors in vagina, urethra, trigone of the bladder, and in pelvic floor muscles. The decreased estrogen level in menopause will increase the pH. So the alkalotic environment is detrimental to not only to normal flora, normal vaginal flora, but also to the lactobacilli. So which is conducive for the growth of the uropathogens. So what does the NICE guidelines say? In postmenopausal women, use of vaginal estrogen is effective, but in the usage of systemic estrogen is not recommended because of the possibility of breast and endometrial C. What is the role of urethral dilatation? And the studies show that between the group which had the dilatation and without, that there is no difference in the number of recurrent urinary infection with dilatation. So, but subjectively, 30% of the patients reported complete resolution and 50% reported improvement. And there is one more thing called the glycosaminoglycans, which is the urothelium has 3 layers. And you know, the surface layer is covered by glycosaminoglycan, which is hydrophilic, and it acts as an antibacterial coating of the bladder. So what really happens is, if you replace the gag layer with synthetic hyaluronic acid, then it can improve the quality of life without increasing these adverse effects. So there are European studies which shows that improvement is quite likely with the use of intravesical glycosaminoglycans. But with antibiotics, you have the risk of developing resistance, but this glycosaminoglycan has no such possibility. What about vaccines? We have vaccines like Urovaxom, parenteral IM, and vaginal suppositories. So they all have been tried. But one thing we all have to remember is all these vaccines, the organisms can evolve, mutate, and reduce the effectiveness subsequently. So sublingual vaccination is not licensed in UK, not approved by US FDA. So, but this double-blind RCT is going on, comparing the Euromune with the placebo, and maybe the future will be that of immunoprophylaxis. Ladies and gentlemen, what about the recommendation based on evidence? There is a moderate recommendation, say grade B recommendation for vaginal estrogen therapy in postmenopausal women. And there is grade B recommendation, strong recommendation for the OM89, the immunoactive prophylaxis. But there is no recommendation for cranberry. Regarding the urinary pH, ladies and gentlemen, as I told you earlier, there are certain organisms, they thrive in acid urines and certain organisms in alkaline urine, and certain antibiotics like this, they are effective in acidic pH, and quinolones are all effective in the alkaline pH. So what really happens is, if you use the citralca, you will increase the pH, but at the cost of the possibility of developing tachycardia, bone loss, and there can even be sodium overload in hypertensive patients. So please remember to use a potassium alkalizer, which has least side effects, avoid sodium overload, and reduces the chance of bone loss, and safer to be used with quinolones. So lifestyle intervention, drinking, you need to have 6 to 8 glasses of water. If you reduce water intake, highly concentrated urine is produced, which will irritate the bladder and worsen the symptoms. Avoid using coffee, tea, soft drinks, and alcohol. Even spicy food can cause irritation. So voiding habits, one should not delay void. Every 2 hours, one should resort to voiding. The reason being, according to the calculation, in say in 20 minutes with a 300 ml volume and the post-void residue of 3 ml, the bacterial population will just achieve its previous density in 2 hours. So it is imperative that you empty your bladder within 2 hours in UTI. And then one word about hygiene. So we request all our children and the school-going kids to follow the hygiene format. That is, you tell them to wash the genital area after passing urine. And if they are used to the habit of using the toilet tissue paper, then let them use it from front to back. That is very important. Ladies and gentlemen, I would conclude by saying, you please remember not to prescribe sodium containing alkalizer to your patients, and remember to use potassium alkalizer like K-MAC, which has many advantages. Ladies and gentlemen, I also at the end request you to participate in a small survey which will provide some information about the status of urinary infection with us. And with this, I would like to thank and request the chairpersons to proceed with the further sessions. Hello?
Thank you very much, ma'am. Thank you very much. It was really an excellent presentation, ma'am, because you were just on time. At the same time, you had to switch over your presentation. So really great of you. Hemnath, if you're finding a little difficulty in Hemnath Goyal sorting out the sessions, can we Hemnath move to the next session and come back to you, the next speaker and come back to you?
No.
If we can have the next speaker, Dr. Jai Ganesh, ready?
Is Dr. Hemant ready? Let him answer first.
There is some problem. I am trying to share just.
Okay,
Hello?
then we are moving forward.
Hello, Hemant? Hemant, can you hear me?
Yeah, it is visible, sir. Your slides are now.
Your slides are visible, Hemant. Yeah.
Slides you can, screen is visible. You can share the slides. Yeah.
Close. Minimize.
So my slides are now visible.
Slides can be opened. That will be visible. The screen is visible.
Yeah. So now it's okay.
Yeah.
Yes.
Yeah. Now it's visible.
I'm very sorry. I'm very sorry for this delay. So at the outset, I would like to thank the entire organization, Dr. Raja Maheshwari ma'am, for giving me this opportunity. My topic is antimicrobial treatment in women, in UTI in women. I'm Dr. Hemant Kumar Goyal. I'm head of department urology and renal transplantation at RML Hospital, Delhi. So at introduction, urine is not always normally sterile. So we will try to bust some myth and mystery, which is a concept of this topic, and I'll stick to treatment of UTI in the sense that when to start antibiotic, what is the optimum antibiotic to start, what are the optimum duration of antibiotic, and I'll stick more of uncomplicated, acute uncomplicated UTI in female. I'll try to cover that. So urine is not always normally sterile. There are large amount of commensals which we have recently found which can be normally present in urine. Should not overdiagnose and expose patient to unnecessary antibiotic. Antibiotic stewardship, clinical presentation with properly collected urine analysis is very important, as already told, and guideline to be strictly followed for choice and duration of antibiotic. So the management of UTI is antibiotic, supportive treatment, lifestyle and home remedies, and follow-up. So I'll cover the antimicrobial part. So when the patient come, you should know when the patient, we can do an outpatient basis treatment and when the patient has to be admitted. So when there is a severely ill patient, evidence of sepsis, presence of complication, when there is a concern about compliance of the patient, failure to respond to outpatient treatment, and there is uncertainty about the diagnosis, we should admit the patient. Otherwise, all patients should be treated on outpatient basis. So about 99% of the patient we can treat on outpatient basis. Now, the most important question is the selection of antibiotic. So for selection of antibiotic, we should have some information about evaluation of UTI. What was the recent infection or antibiotic use in the past, recent hospitalization status, any comorbidities, history of pediatric voiding dysfunction, any sexual and reproductive history, anatomic urological abnormalities, prior surgery of genitourinary tract, family history of UTI, and current medication. Very important part is urine analysis and appropriate urine culture. So this is a screenshot of a urine culture which is showing E. coli of more than 10 to the power 5 colony forming unit per ml. So now one of the myth is a antibiotic with a minimum inhibitory concentration is the best antibiotic. So that is not always the case. Now you can see in this, there are a lot of antibiotic which are sensitive. So we have to see whether we want to give antibiotic for an uncomplicated UTI or a complicated UTI. Again, a complicated UTI is divided into outpatient treatment and inpatient treatment. So like you can see, a nitrofurantoin has an MIS of less than 32. So yeah, so nitrofurantoin has a minimum inhibitory concentration of less than 32. So it may be there may be an impression that it is not a good antibiotic for this urine culture. But if nitrofurantoin has a very good urinary concentration, so although the MIS is less than 32, but the urinary concentration are often high. So it is a very good antibiotic for acute uncomplicated UTI where we want to have a good urinary concentration. Now, if it is a complicated UTI, in this scenario, levofloxacin is very good, which are with a low MIS and a good blood and urinary concentration. Whereas amikacin will be good when there is it will have a good blood concentration. So if there is a kidney or prostatic, like not in female, but if there is a parenchymal involvement of kidney like pyelonephritis, amikacin will be a very good antibiotic. So it has to be appropriately studied, the urine culture, and a antibiotic with very low MIS is not often a way of antibiotic of choice as per urine culture. So how do you select whether it is a complicated UTI or uncomplicated UTI? What are the potential adverse effect of a given agent, drug, cost of the drug, concentration of antibiotic in urine and blood? So this is very important. Uncomplicated UTI, we want to have good urinary concentration of antibiotic, whereas in complicated UTI, we want to have good blood and urinary concentration of antibiotic. So it has to be judicially selected. Now, we should have a knowledge about the dosage modification in renal and hepatic insufficiency. Impact of vaginal and bowel flora is very important. For example, nitrofurantoin and saptran, they have minimal impact on vaginal and bowel flora, so they have minimal collateral damage. And whereas fluoroquinolone, they have impact on vaginal and bowel flora, so they have a lot of collateral damage and bacterial resistance. That is why they should not be used as first-line drug in uncomplicated UTI. Now, antibiotic susceptibility pattern should be known in that particular area where you are practicing. Now, acute uncomplicated cystitis, they rarely progress to severe disease, even if untreated. Thus, the primary goal of treatment is to ameliorate symptoms. Now, this is a very important statement that acute uncomplicated UTI is the treatment should be to aim to ameliorate symptom rather than to treat UTI. the clinician should select an antimicrobial agent with a urinary concentration that exceeds the minimum inhibitory concentration. They should avoid underdosing and emphasize patient compliance. Now, UTI is a very, very common problem, and the inappropriate use of antibiotics is even commoner. So that has to be avoided. So we should know whether the antibiotic is bactericidal or bacteriostatic. So most of the fluoroquinolone and your IV antibiotic are bactericidal. Nitrofurantoin is generally bacteriostatic, but it can be bactericidal in high doses and certain organisms. Now, before prescribing antibiotic, we should know common adverse reaction, precaution, and contraindication for that antimicrobial agent. So fosfomycin is a relatively safe drug with few adverse reaction and few precaution. Only hypersensitivity to fosfomycin is a contraindication. Penicillin is not available in India. I've never used. Nitrofurantoin, you should know the common adverse reaction are GI upset, peripheral polyneuropathy. Very important is hemolysis in patient with G6PD deficiency, so avoided in neonates and third trimester pregnancy. Pulmonary hypersensitivity can range for acute or chronic. It should not be used in patients which have low creatinine clearance of less than 50 ml per minute. We should monitor for long-term patient closely. Avoid concomitant probenecid use and avoid concomitant magnesium and quinolones. Septran is again have a lot of side effects. It has hypersensitivity, basically skin side effects, rash, GI upset, photosensitivity, and increased side effect in immunocompromised patient. We have to avoid in pregnant patient. We should avoid in patient receiving warfarin. So I would like to tell about fosfomycin. It is an oral bactericidal antimicrobial agent. It has efficacy against majority of gram-negative organism and vancomycin-resistant enterococcus. It is effective as a single-dose agent when used and empirical treatment for uncomplicated UTI. It should not be used in the setting of urosepsis or blood-borne infection. So fosfomycin is an antibiotic with a single dose. We give a 3-gram sachet of fosfomycin, but it should not be used for antibiotic prophylaxis, for UTI prophylaxis, and it should not be used in complicated UTI. It is only to be used in uncomplicated UTI. That is very clear, and it can be used in a number of resistant settings. Fluoroquinolone is a very important antibiotic in UTI. So we should know important side effects of the drug, like mild GI side effects. Very important side effect is central nervous system effects, including dizziness. It decreases the threshold for seizures and a tendon rupture. So it has to be avoided in children, pregnant patient because of arthropathic effects, and it lower the seizure threshold to avoid in patient with epilepsy and in patient with other risk factors that may lower the seizure threshold. Also, they can enhance warfarin effect, so closely monitor coagulation test. This is a very important statement which I have seen is fluoroquinolone should be reserved for use in patients who have no other treatment option for uncomplicated urinary tract infection, because the risk of these serious side effects generally outweigh the benefit in these patients. So it is one of the very common antibiotic, first antibiotic which is started in UTI. It should not be started. We have better antibiotics. This is a very good antibiotic, should be reserved for only those cases where we don't have other option for uncomplicated UTI. So this is a very important chart. IDSA recommendation for acute uncomplicated cystitis. Women with acute uncomplicated cystitis, where there is absence of complicating factors like flank pain, fever, or other suspicion of pyelonephritis, if there is such a scenario, the first line antibiotic is one of the three. We can start with nitrofurantoin, monohydrate, or macrocrystals 100 milligram for 5 days. This is for 5 days. Or we can start Septran, that is trimethoprim, sulfamethoxazole 960 milligram, BD for 3 days. We have to avoid if the resistance prevalence is more than 20% in the area where we practice. Or we can start with fosfomycin, 3 grams single dose. The efficacy is lower as compared to 3-day treatment, but still these three are first line treatment for uncomplicated UTI in female. Nitrofurantoin for 5 days, trimethoprim, sulfamethoxazole for 3 days, or single dose fosfomycin. Only in the condition where we cannot give these drugs, we consider fluoroquinolone, and that has to be given for 3 to 5 days again, or beta-lactam antibiotics. So the choice between these agents should be individualized and based on patient allergy and compliance history. local practice patterns, local community resistant prevalence, availability, cost, and patient and provider threshold for failure. So this is a very, very, very important slide where the first line treatment has to be either nitrofurantoin, Ceftriaxone, or fosfomycin single dose. Fluoroquinolone reserved only for cases where these cannot be given. Whereas for a complicated UTI, we have to see whether it is a mild to moderate or severe case. In case of mild to moderate case, we can treat on outpatient basis. And here the first line treatment is fluoroquinolone because we want an antibiotic which has higher blood as well as urinary concentration and oral drug. So the first line treatment here is fluoroquinolone, where the outpatient treatment is for 7 to 10 days. And once the patient is improved, whereas in severe cases where the patient presents with fever, sepsis, we have to evaluate for radiological evaluation for complicating factors. We have to send blood and urine culture. Inpatient, we have to hospitalize the patient for till the patient is afebrile, and we start with IV antibiotic because we want an antibiotic which have higher blood concentration. So these are ampicillin plus gentamicin can be used, IV fluoroquinolone can be used, or third generation cephalosporin can be used. If there is improvement of the patient, we switch to oral treatment. Within 24 hours, the patient becomes afebrile, and then we continue the treatment for next 14 to 21 days. Very important is in uncomplicated UTI, there is no routine follow-up is required. We don't have to prove with urine culture whether it has become negative. Only thing is patient has to be asymptomatic. If the patient is asymptomatic in an uncomplicated UTI, in this one, when the patient is asymptomatic, nothing has to be done. No follow-up urine culture is to be done. But in complicated UTI or in uncomplicated UTI, when the symptoms have not resolved, you have to repeat culture on 5th day to the 5th to 7th day of the therapy on therapy, and 10 to 14 days after discontinuing antimicrobial therapy to ensure you have eradicated, you have completely treated the UTI. So this is a gist of appropriate selection of antibiotic, duration of antibiotic, and complicated and uncomplicated UTI. So I conclude with this. Thank you.
Thank you, Dr. Hemnath. In fact, it is a wonderful topic. Any number of times that topic can be repeated again and again, especially in those cases where people started using fluoroquinolone as a first line of treatment. Thank you very much, Dr. Hemnath. May we have the next speaker, Dr. Jai Ganesh, ready, sir? The next topic is going to be on prevention
Is Jai
of urinary
Ganesh there?
tract infection.
He's yet to get connected, ma'am. I think.
If you had some difficulties in getting
yeah,
Dr. Jai
sir
Ganesh,
has come. Sir has come. Yeah, sir has come. Yeah.
Sir has come in. As Dr. Jai Ganesh gets connected, Dr. Jai Ganesh is a senior urologist in Chennai. He is currently working in Government Roypeta Hospital. He has got more than 2 decades of experience in urology and is trained in robotic surgery. May we have Dr. Jai Ganesh, sir, on the presentation, please. Dr. Jai Ganesh, sir, you're connected.
Hello? Hello? Jai Ganesh? I couldn't hear him. Can you hear me, Chengal Brian?
Yes, ma'am. You're audible. Dr. Jai Ganesh voice is not.
Actually, Jai Ganesh sir came in. Actually,
I'm presenting his slides.
Yes,
hello, I'm
yes,
slide
yes,
sharing
yes,
from my end, but he will talk.
Yes, ma'am.
Okay.
Is he available?
He came in, ma'am. Actually, just again logged out.
Somebody please call him. Actually, he has sent his slides. I'll be projecting it from my laptop, and he will be talking. Perhaps I think he is tied up with something. Hello. Meanwhile, I think we can take a few questions. Hello.
Exactly, ma'am.
Yeah, now sir is there. Jai
Has
Ganesh
he
sir
come
is
down?
there.
Okay.
Yes. Jai Ganesh sir, can you hear us? You have to unmute yourself, sir.
Unmute.
Hello. I have asked him to unmute.
Whether he has got the speaker link.
Hello.
Yeah, he's
some
in
link
speaker.
issue. Sorry.
Ganesh.
Hello. Yeah, ma'am. Yeah, we can hear you, sir.
Ganesh,
we can hear you, sir.
அந்த ஸ்லைடு ப்ரொஜெக்ட் பண்ணா போதும் மேடம். அந்த லிங்க்
ஸ்லைடு நான் இங்க இது பண்றேன்ப்பா. ஸ்லைடு நான் இங்க ப்ரொஜெக்ட் பண்றேன். நீங்க
You are audible, sir. You are audible.
உங்க ஸ்லைடு
You are
I
audible.
will slide share from my laptop, but can you speak, use your through your phone, you can connect yourself in the link.
ஆமா அதுதான் லிங்க் தான் இந்த
He has come in, ma'am. He has come in, ma'am.
I was able to listen. I was able to listen to all your deliberations. Yes.
சரி, இப்போ என்ன,
No
do you
problem.
want me to project your slides to them?
Yes, ma'am. Yes, ma'am.
Hello, can you ask somebody? Prasanna,
slides மட்டும் போட்டா
ஜெய் கணேஷ்க்கு எப்படி கனெக்ட் பண்றதுன்னு சொல்லுங்க.
Ma'am, he's there, ma'am. We could able to hear him actually.
Yeah, can you hear him?
Yeah. Hello,
Dr. Jay Ganesh, sir. Dr.
Yes,
Jay
sir.
Ganesh, sir, you are very much audible, sir. As Madam projects the slides, we can even talk, sir. Everybody is able to hear you, sir. You are all able to hear you.
Hello, Ganesh.
Yes, sir.
Hello.
Jay Ganesh, sir, you are very much audible, sir. You can start discussing as Madam projects the slides, sir. Madam Jay Ganesh, sir is requesting you to project the slides.
Yeah, I'm doing that.
Yes, ma'am. He'll be talking.
அதுல கிளிக் பண்ண லாகின் ஆகல. எனக்கு என்னோட ஸ்லைட்ஸ் மட்டும் போட சொல்லிடுங்க. வேற ஒண்ணும் வேண்டாம்.
நான் ஸ்லைடு போட்டுட்டு இருக்கேன். Please tell
அது
him.
மட்டும் ரன் பண்ண சொல்லிடுங்க.
Sir, we can hear you and your slides are on. Can you switch on the video, sir?
No, you can talk. Jay Ganesh, you talk.
இல்ல ஸ்லைட்ஸ் மட்டும்
நான் போடுறேன்ப்பா. I'll do that.
நான் பார்க்கறேன்.
You speak.
Hello.
Ganesh, you can talk.
Are you hearing me, madam?
Yeah, I can hear you.
Okay.
I am projecting your presentation.
Sorry for the problem. There was some link issue.
Yeah, this is a first slide. You can talk.
Yes, madam. Yeah. I didn't have the faculty ID. Okay, no problem. Thank you for the opportunity. I was listening to all the deliberations.
Okay, we can hear you well.
Yeah, it was a very good presentations, very useful to all. So coming to the preventive aspect of the UTI, I would like to quote Benjamin Franklin: "An ounce of prevention is worth a pound of cure." Next slide, madam.
Yeah, sure.
So actually, most of the discussions have been handled very well by madam, and she has highlighted the preventive aspects very well. So I don't have nothing much to add actually, except that I can say a good hydration helps us to wash out the bacteria from the urine, and adequate hydration, at least 6 to 8 glasses water is recommended, but we urologists tend to recommend more. Next slide, madam. As you know very well, the female urethra is very short, it's only 4 centimeters. So the bacterial colonization can easily occur from the rectum into the bladder. Ascending infection is very common. So as madam already mentioned, the technique of wiping after using the washroom should be from front to back or not otherwise. And frequent changing of the pads and tampons during the menstrual cycle, and also avoiding the use of feminine deodorants can prevent UTIs. Next, madam. Drinking cranberry juice is known to help. It contains proanthocyanidin, which is very effective in controlling bacteriuria and bacteremia. Next one. Frequent emptying of the bladder. This is what we advise most of the working women who are in the banks, who are in the corporate industries. We tell them you have to drink at regular intervals. So drink water at regular intervals, so that you also empty the bladder at regular intervals. Not postpone the urination until you find a favorable atmosphere for you to use the washroom. That is coming back home from the work after a long hours. That is very, very important. And I also ask them to avoid sweetened products and spices. It also seems to help, apart from taking a high fiber diet. The other important advice for women is that they should empty the bladder before and after intercourse, and they should avoid tight undergarments, and genital washing with warm water is very helpful. Frequent emptying of the bladder prevents UTI. Next, madam. The diaphragm, which is used for birth control, is known to increase UTIs. Water-based lubricants are generally advised because they prevent vaginal dryness and avoid spermicide for preventing UTIs. As I already mentioned, avoid tight-fitting dress so that there is more aeration and helps you to dry after urination. Use of cotton underwear is very preferable to prevent extra moisture being trapped around the urethra. Next, madam. Estrogen containing vaginal cream, particularly in postmenopausal women, it changes the pH of the vagina. Thereby, it can prevent UTIs. And probiotics are also known to be helpful supplements while you manage bacterial UTIs. Thank you, madam. Sorry for the
thank you. No problem.
delay. Yeah.
That was a very crisp presentation, sir. In fact, short and a crisp presentation.
Thank you.
May we go into the question and answer session?
Yeah, sure.
Yeah, thank you very much, ma'am, for this opportunity. And also thank my co-chair, Dr. Neeta Takrit from Ahmedabad, for having an excellent chair. I think it's time for Professor Sahiba Akhtar from Bangladesh, Dr. Shahuta Tahir from Pakistan, and Poonam Mathur from Indore to take over the question and answer session.
Thank you, madam, for the opportunity.
Hello.
Hi.
Hello.
Everyone.
Hello. I think do you have questions from the question answers section of the chat?
In the chat section, yeah, there are a lot of questions.
There is a chat section. Madam, you can see the chat section and you can choose the questions that is relevant with the relevant for the discussion.
Madam, can we ask you a question, madam?
Thank you, Jai Ganesh, and you did a wonderful job.
I need to ask
you really touched which are all the things that I have left out. That's a very nice presentation.
I have a question.
Thank you very much. Yeah, please go ahead with the question.
What is how much of importance you give for the bacterial cultures, madam, in your practice? Because we quite often find people carrying bunches of culture reports, and then they themselves prompting us to start this antibiotic and that. I wanted your opinion on that.
Yeah, that is what the NICE and the RCOG and AUA, American Urology Association, they all advocate not to start an empirical treatment, and if you want to prescribe antibiotic, have the culture sent for growth sensitivity and then start the treatment. And I think only if it is an acute, uncomplicated UTI for the first time, then perhaps we are justified in starting empirical antibiotic. In all other cases, we have to send the sample at least, and then you can start. That is with the clinical practice, but it is the message is that we are not supposed to start antibiotic to our patients without considering the sensitivity and culture. Madam Sahiba Akhtar,
there is a question, and what is the ideal approach in repeated UTI in normal women, pregnant women, diabetic women, and postmenopausal women?
Pregnant women, we have a separate session. I think we should
there is
not,
another question: what is the coital habits are to be counseled to repeated UTI?
Yeah, that's what I think. I request Jai Ganesh to. The question can be addressed by Jai Ganesh.
Just as we mentioned, madam, we advise them to have a empty bladder before and after intercourse, and also the use of warm water to wash the private parts also helps. Apart from adequate hydration. Yes, ma'am.
Yeah, and there is one more thing in the TV. There are so many advertisements saying we wash and this wash, that wash, so many chemical things, and you know that commercializing everything. I don't think we should recommend our women to use any of this chemical washes unnecessarily. So using talcum powder or the wash chemicals, I think it should be avoided. What do you think? And the panel can. Hello.
Yeah.
You know, every pharma company comes with some kind of solution saying that without even any prescription from us, they can out of the counter they can get it.
Yes.
Okay, all those things. So perhaps we should look into it in future.
One question I would like to...
Yeah.
It is not good for the patients.
No.
Yes.
Yeah.
Even ma'am, soaps, Dettol and all are also not good because vaginal pH can alter. So it's best is the lukewarm water for local.
Absolutely.
That is the best thing.
Foam, not the direct soap.
Yeah. In fact, I've seen quite a few patients.
There is a question.
Yeah, I seen quite a few patients who were very fastidiously rubbing their genitalia after washing urine, especially perimenopausal patients, including gynecologists, some of them. And then they would have small micro abrasion, then infection, then UTI. And when they stopped using all that, they got much better. And probably like, the estrogen cream also helped them. So I think avoid using any such wastage and all. The simple plain water, as Amita and Nita has said, I think.
So if water is available, better to use plain water, provided it's the clean water. If water is not available, perhaps they can use the toilet tissue, but without causing abrasions, and from front to back. Okay.
Yes.
The question I would like to ask: what are the recommendation for use of this extended spectrum urine culture? Because nowadays many labs are doing this extended spectrum culture, and unnecessary reports are coming positive because we are using extended. Basically, what I know is we should use a normal culture, urine culture, and extended spectrum only in cases where patient is symptomatic despite our antibiotic. We think we are missing some abnormal organisms. So, what is your practice, ma'am?
Yeah, I think Hemant, it's a very good question. I agree with you, and we should go by the standard culture. And unless it is specially needed, they will not go in with this special kind of extended ESBL and all those things.
Thank you.
I think we are getting delayed. Should we move over to the next session?
Yes, ma'am.
Yeah. Can we thank everybody and
thank you.
Professor Shahupta Tahi, please go ahead.
I would like to comment on it because the session is very informative, and in fact the talks were all very good, and it's very good and nicely organized. And your talk, Madam Rajit, was really nice because you covered most of the things in it. And the thing you discussed was the COTI, and that is the involvement of the candida, emphysema of the bladder. It's rare. In fact, I have not seen it, Maybe the urologist people, they may have seen, but we being the gynecologists, I have not seen it. No? But this is, yes, it's the question that must asked, because some of the women, they say that I pass the gas, in the urine, and it's something important. It should not be missed. So it's a very good part of it. You covered everything very nicely, and the session went very nice. Thank you very much for inviting us. And I think you would like to continue it, or if there is some question.
Please stay on, all of you. Thank you very much for all the chairperson speakers who did a wonderful job. And most importantly, the participants.
Thank you for giving us the opportunity.
With your permission, we can move over to the session 2. And shall we call upon the chairpersons? Thank you, Chengal Ryan. We'll call upon the chairpersons of the session. Yeah, thank you very much. Section.
Hello.
Yeah. So we have session 2 exclusively. Exclusively for the UTI in pregnancy, and because it may not be that frequent, but still it is a very important topic that should be. Do you have the slides?
Yes,
hello?
We could see.
May I call upon Professor Vijaya, OBGY professor, and she is the director of the Institute of Social Obstetrics. Is Professor Vijaya there? Hello? Is she connected?
Yes, ma'am. She's connected, ma'am.
She's connected. Okay. And she is number 1 OBGY professor in the city. And she has lots to her credit as national level master trainer, skill lab, and state level master trainer in EMONG. And she is an examiner for the undergraduate, postgraduate courses. And she is a state level master trainer in cervical cancer and screening colposcopy. And then we have our eminent gynecologist, Dr. Ramani Devi from Trichy, and she's the managing director of the Ramakrishna Medical Center and the Janani Fertility Center from Trichy. Currently, she is the vice president of the FOXY, the Federation of Obs and Gynae, and she's also in the International Advisory Board of Fertility Society of Bangladesh. And we have our Shama Kanugo Madam, a senior professor obstetrics gynecology, and I have a lot of respect and regards for from Professor Shama Kanugo, who is very much into teaching, training, and research. And we owe so much to you, Madam. Well, I welcome you to the panel as one of the.
Thank you, Raji.
And then we have the young Umarani Madam, who is a very, active urogynecologist and gynecology doing practice at Max Super Specialty Hospital. And she is well known for all her academic work, and she is a very good surgeon and excellent human being. I welcome you, Uma. And we have Mohan Chandra Rajni from Nepal, and I'm not sure whether he has his connectivity. He is running the program of Ayuga Fellowship Program in Nepal, and he's a fistula surgeon. And we have Meena Mahalingam and Dr. Narmada. They are from the Institute of Social Obstetrics. They are a program coordinator along with Jessima Subhani, and she is assistant professor from Madras Medical College. And with this, I would like to hand it over to the chairperson, and we have Professor Subhash Chandra Biswas, and he is professor of OBGY, and he's a very dear friend of us, and he is a very good surgeon and excellent teacher, and has an excellent rapport with each and everybody. I welcome you, sir. I hand over the session to you all. Thank you. Hello, chairpersons, please.
Good evening, Madam Rajamageshwari. I really congratulate you for the effort that you have taken to conduct this excellent program. I am happy to say for the audience that I was a student of Professor Rajamageshwari, and I am happy to be a part of a problem course today. And the first session went on extremely well. And for the second session, especially for the obstetrician, the topic of interest is urinary tract infections during pregnancy, which is going to be one of the very common problems what we face during pregnancy. And to talk about it, we have great speakers like Professor Dr. J.B. Sharma from Delhi, Dr. Sita Lakshmi from Chennai, Dr. Meera Raghavan, Dr. Aparna Hegde, and Madam herself, Lily Varghese from Vellore, and Srikala Prasad, Dr. Amita Jain. I have the pleasure of first welcoming Professor Dr. J.B. Sharma from Delhi, who is currently the chairperson of urogynecology of Foxy.
Okay.
Hello.
Yeah. Thank you very
Sir,
much.
I'm projecting the slides from my end. You can go ahead and talk.
Okay. I can say that.
Welcome, Dr. Professor J.B. Sharma.
Thank you, madam, for your nice introduction, and my good afternoon to everybody, and great salute to Dr. Raja Maheshwari for such a wonderful organization of such a simple topic. I was wondering that, in UTI, how will we spend time? But now I can realize that still I think UTI has long way to go. So after doing UTI in gynae, I think now it's time to do introduction and prevalence of UTI in women during pregnancy. So thank you very much, madam, and Dr. Ramani Devi for the nice introduction. Next slide, ma'am.
Yeah.
So we all know that some part will be duplication because they were covered in gynae also. So we all know that kidney, ureter, bladder, urethra are the part of the urinary tract. But what I want to highlight is that bladder and urethra are the lower urinary tract, while kidney and ureter are the upper urinary tract. And this is very crucial actually, because any infection of the upper tract is very, very serious, can be life-threatening during pregnancy, can cause miscarriages, can cause IUGR, and can be even life-threatening and septicemia. So this is what we some part already covered, that we have mucosal immunity in the urine, and why we don't have infection in pregnancy or otherwise, because of the immunity system, what madam highlighted, Dr. Raja Maheshwari in her lectures. So there is inherent tendency like acidic pH intolerable by pathogens, high urine osmolarity, mechanical flushing of urine flow, and then mucosal immunity there, urothelial secretion of cytokines, chemokine, mucopolysaccharide, mucosal IgA, and in men prostatic secrets which have antibacterial action. So these are important. So UTI is a microbial infection of any part, both upper and lower urinary tract infections, among the most common bacterial infection worldwide, and every second woman will experience at least one episode in her lifetime, and it is usually self-limiting. but can be recurrent also. Next, please. Yeah. So worldwide, almost 150 million women are diagnosed with UTI every year, costing global economy in the cost of $6 billion US. Next, please, ma'am. So it's a very, very common problem, and I think day in and day out we are seeing UTI patients. And incidence is more common in female, 53% as compared to male, 46%. And this all of us know because of the short urethra in female, close proximity of urethra to the anal canal, and the wiping habits in India, as Dr. Raja basically highlighted in the previous lecture, that we must train our adolescent, our young girls and children to wipe from front to back rather than the other way around. And it is estimated that about 35% of healthy women suffer symptoms of UTI at some time in their lifetime. Next, please. Yeah, so it increases with age and especially postmenopausal women, but in pregnancy, the women are much more prevalent. Next, please. Okay, so why great susceptibility of UTI in women? Next, please. So we all know that they are because of the short length of urethra, proximity to anus, which we have said, and wiping habits. Next, please. Okay. So this we have already highlighted, that upper, and lower. So isolation of specified. So urethritis, cystitis are the lower UTI, while urethritis and pyelonephritis is the upper UTI. Next, please. Okay, so we know that the symptomatic bladder infection characterized by frequency, urgency, dysuria, suprapubic pain in a woman with normal genital tract and associated with both genetic and behavioral determinant, and isolation of specified bacteria. Usually we take 10⁵ bacteria per cubic ml. That's the CAS principle. But as Madam said, that in case of catheter, this thing 10⁵ bacteria are also highlighted. So in 1000 bacteria can be taken seriously, but by definition it is 10⁵ bacteria. Next, please. Okay. Next, please, man. Okay, so acute cystitis, that means more than 10⁵ bacteria, and the recurrent UTI will be there more than 2 UTI in 6 months or more than 3 in 1 year. And acute pyelonephritis is basically upper urinary tract infection, while chronic pyelonephritis is chronic infection of kidney, pelvis, and ureter. And sterile pyuria is when you get white cells but you don't see bacteria, and that is important cause in India is the tuberculosis of the urinary tract. So we must always look for that also. I'm seeing a lot of such patients, and recurrent UTI is more than 2 UTI in women. So these are the risk factors. Healthy premenopausal women, sexual behavior, hormonal deficiency, diabetes, pregnancy, relevant immunosuppression, long-term catheter, urethral obstruction. Next, please. Yeah. So E. coli, already Madam highlighted, 80 to 85% staph, Saprospicticus, Klebsiella, Proteus, Pseudomonas, a viral and fungal agent, already highlighted by ma'am. And ascending infection through urethra, especially organism of enteric origin, usually Enterobacteriaceae family from the from the anal canal, and then the blood-borne are Staph aureus and others. And this slide already Madam has shown it, so we can skip it. That infection goes from below up, but sometimes can come from the bloodstream also. Next, please. So during pregnancy, basically about 5 to 10% actually is the prevalence of asymptomatic bacteria. And there is this thing, should we be doing? I was part of the meeting in Royal College London, that should we be doing routine culture for all patients still in pregnancy because the prevalence is less than 5%. But in the end, the discussion came, yes, we should. We continue to do the diagnosis because we can pick up asymptomatic.
Ma'am, slide not visible. Ma'am, slide not visible.
Okay, I think slide almost
slide is over.
That is over. So I'm just I finished in 30 seconds. So what I want to highlight that asymptomatic bacteria is about 5% incidence, some places 10%. So we should continue to do the urine culture routine for all pregnant ladies in usually at the end of first trimester, 12 weeks or so, when the first visit. And because we can pick up asymptomatic bacteria, then we can treat it. Otherwise, some of them will become symptomatic bacteria, some of them will become pyelonephritis, which has a great bearing, because pyelonephritis can cause abortion, it can cause preterm delivery, it can cause intrauterine death, it can cause other complications also, and can be life-threatening for the mother. So I won't go into the detail of the treatment and all that will be covered, but we must continue to do routine culture on all pregnant ladies in pregnancy in the first visit itself, and may repeat it if need be. Thank you very much.
Thank you, Professor Sharma, for your excellent presentation and highlighting the fact that women are prone for UTI during pregnancy and importance of asymptomatic bacteria you have brought out, and the need for doing a routine culture sensitivity. I think it is an eye-opener for many of the obstetricians, because unless they have a UTI symptom, they generally don't do it. But it is always advisable to do routine urine culture in each trimester so as to avoid the pregnancy complications like IUGR or preterm labor, which is very, very common during pregnancy. Thank you for highlighting all those important points. Thank you, sir.
I think next speaker, Ramani. Ramani.
Yes, Dr. Sita
Professor
Lakshmi.
Sita Lakshmi.
Sita Lakshmi from Chennai.
Yeah.
She is going to give us a talk about pathophysiology and clinical manifestations of urinary infection during pregnancy. Her CV, if you can project her CV, can you do it?
It will come along with her presentation, a single PPT.
Okay. I request Dr.
Is
Sita Lakshmi to...
Sita live? Yeah.
Yeah. Professor Sita Lakshmi is from Institute of OBGYN and Government Hospital for Women and Children, Madras Medical College, Chennai. Welcome, madam.
Hello, Sita. Hello.
She has to unmute herself.
She's there?
Yeah. Unmuted only. Yeah. Hello, ma'am.
Can somebody call Sita and tell her?
Sita, madam, can you start your presentation? Its slides are already projected. Unmute, madam.
You can talk.
Professor Sita, unmute. Yeah.
Already unmuted, madam.
Yeah. You can start your presentation.
Hello. Mageshwari, madam. Am I audible?
You are audible, yes. Sita. Yes. Please go ahead.
Start.
Little louder.
I thank Professor Rajamaheshwari,
Sita,
madam.
Your volume is low.
Keep closer.
I thank Professor Rajamaheshwari, madam, for giving me this opportunity to talk in this seminar. I'm going to talk on pathophysiology and clinical manifestation of UTI in pregnancy. Women are 14 times more susceptible for urinary tract infection than men, and pregnant women are more susceptible to urinary tract infection. The UTI is defined as the presence of 100,000 organisms per ml of urine in asymptomatic patient, or more than 100 organisms per ml of urine, which is more than 7 WBCs in uncentrifuged urine. So the types of UTI varies from asymptomatic bacteriuria through the significant bacteriuria evolving to acute pyelonephritis. The significant bacteriuria is the presence of more than 100,000 colony forming units of single organism. Asymptomatic bacteriuria is more than 100,000 colony forming units of same bacteria, which occur in any trimester of pregnancy, more common between 6 weeks to 24 weeks, where the renal changes are more, resulting in more dilatation of the renal pelvis. The recurrent UTI, more than one UTI before or during pregnancy. So the risk factors for UTI during pregnancy are diabetes, recurrent UTI, and the pregnant patients with the blood group antigens A, B, and H, and the pregnant women with the structural anomalies of the urinary tract with the sickle cell disease, teenage pregnancy, low socioeconomic status with poor hygiene, and 80% of UTI are caused by E. coli, 10 to 15% by Klebsiella, and Protease is 5%. Even though group B streptococcus and ureolyticum are rare causes, they can cause severe chorioamnionitis and neonatal complications. The other risk factors are pregnant women with neurogenic bladders and elevated risk after midurethral sling. So the etiopathogenesis is because of increased urinary stasis and vesicoureteric reflux due to physiological hydronephrosis and decreased bladder tone and increased urethral peristalsis, along with glycosuria and altered pH, is the etiopathogenesis for urinary tract infection. So the ascending bacterial movement and propagation through urethra from the colonized perineum, which result from vesicoureteric reflux, and the source of bacteria is always from rectal reservoir. So the types of UTI, asymptomatic bacteriuria account for 2 to 20%, which usually occurs in first trimester and multiparous. The cystitis contribute to 1.3% and pyelonephritis is 2 to 4%. So the clinical presentation is urethritis, which has a low grade of severity. Cystitis is a moderate grade. Pyelonephritis is a severe and established grade of urinary tract infections. So the clinical manifestations of acute cystitis vary from urinary frequency, urgency, dysuria, which are the features of cystitis and urethritis, may or may not accompanied by hematuria or pyuria. 90% of the infection is limited to the bladder, and mucopurulent cervicitis coexist. And whenever the patients have severe flank pain, fever, vomiting with loin tenderness, always suggestive of pyelonephritis when untreated leads to acute renal failure, and the fetal risk or preterm birth, low birth weight infants, and the maternal risk or preeclampsia, anemia, and preterm labor. So the key points: significant changes in urinary tract stasis leads to vesicoureteric reflux, which are the predisposing factors for UTI. Asymptomatic bacteriuria is present in 5 to 6.5% of the pregnant women. When it is untreated, leads to acute pyelonephritis in 40% of the patients. ASB is associated with the PIH, preeclampsia, anemia, preterm labor, low birth weight. Gold standard for diagnosing asymptomatic bacteriuria is the urine culture. Maternal and fetal prognosis is good if the renal parenchyma is at the most moderately compromised in acute and chronic pyelonephritis. Thank you.
Hello?
Okay, shall we invite the next speaker?
Yeah, please, please.
It's my pleasure to invite Meera Raghavan of Chennai. Please come forthwith. We have already lost a lot of time. Meera Raghavan, I think you should share your slides.
Ready, ma'am.
Welcome, Meera.
Hello, good evening. Can you all hear me?
Yes, we can.
Yes, the slides are visible, I hope.
Your slides, please.
Yes. Amen.
Hello, go ahead, Meera.
Yeah. Thank you, ma'am, for the wonderful opportunity. Hello, everyone. I think most of it is covered, and we understand this is the most common medical complication in pregnancy, and not only can impact the maternal health, but also can have neonatal as well as perinatal complications. And those have been enumerated already. And this is one point where we need to understand why we need a test of cure, both for the asymptomatic bacteriuria as well as a complicated or an uncomplicated cystitis. Unlike in the non-pregnant state or the male counterpart, during pregnancy, we do need a test of cure. Otherwise, we will not be able to treat recurrence, which will then require prophylaxis. And a persistent urinary tract infection in pregnancy can lead on to the enumerated maternal as well as neonatal complications. So UTI in pregnancy can be an asymptomatic bacteria in pregnancy, which doesn't classically fit into infection, but because of the far-reaching consequences needs our attention. Next comes the acute uncomplicated cystitis, and then the complicated where there can be an ascending infection. 10% of pregnancy can have ASB, about a 10 can have UTI, which is symptomatic. 5% can go on to have pyelonephritis, and amongst them, 5% can have recurrence. These are the implicated microbes, which we already know, and how do we find them out? So all pregnant mothers should be screened for UTI in pregnancy, and antibiotics should be commenced without delay. So when is the best time to screen them? Between 12 and 16 weeks at your booking visit. Do a urine routine and a culture whereby we detect the evidence of asymptomatic bacteria. Evaluation, always do a pelvic examination if there is features of white discharge. Usual complaints of increased frequency, nocturia, and suprapubic pressure are not helpful because any of them would have it because of the increased pressure from the gravid uterus, expanding plasma volume, the GFR, and the renal blood flow. Asymptomatic bacteriuria, more than a lakh of one or more two pathogens in two consecutive midstream catch. We have to educate our patients about the midstream catch. Otherwise, we always get it as contaminated and the need for repeat culture. Cystitis, the classical presentation of dysuria, frequency, urgency, suprapubic pain, tenderness, the presence of hematuria warrants further imaging. Pyelonephritis by flank pain and tenderness, high temperature, shaking chills, nausea, vomiting, features of sepsis, and tenderness in that area. We've already seen Professor Sita Lakshmi enumerating the risk factors which occur during pregnancy, mostly as a result of the anatomical and the physiological hydronephrosis, which operate in tandem during pregnancy to make the woman high risk of the disease. However, there are certain predisposing maternal factors such as diabetes mellitus, sickle cell trait, gout, and cystic renal disease. So screen for them in somebody who is presented with previous UTIs in pregnancy or during the current pregnancy. Investigation, urine culture is a must. Dipstick is a way to screen, and it's quite reliable in the presence of nitrite and leukocyte esterase. Professor Rajamaheshwari has already detailed about the diagnosis earlier. CBC and the blood urea nitrogen and creatinine. Imaging is needed if you're suspecting upper tract or when there is a calculus which is suspected. Urine cytology in the presence of hematuria. Gold standard, culture and sensitivity. Do not need to do extended spectrum. The standard culture and sensitivity is good enough. So screening should be done in all pregnant women in the first trimester so that we detect if they are positive or negative. If there is no asymptomatic bacteriuria, you can continue. But in high-risk pregnancy, say for example, recurrent preterm labor, one who's had a cervical stitch twin pregnancy, diabetic women, screen them every trimester. Acute cystitis in pregnancy, again, the full gamut of urine analysis along with urine culture, confirm cystitis if it's more than 8 pustules with a positive leukocyte esterase and nitrate test. I'm just reiterating whatever Madam has already said. The most important caveat in non-pregnancy as opposed to in pregnancy as opposed to non-pregnancy is after 2 weeks, do the urine culture to confirm the eradication of the bacteriuria. The persistence of infection can be wrongly termed as recurrence, and we have not treated adequately for adequate duration and adequate dosing with the appropriate antibiotic. So the appropriate antibiotics, I think it is not in my thing to tell you, but definitely nitrofurantoin, cefalexin, and fosfomycin now are the appropriate antibiotics, and you follow them up after 2 weeks to prove a negative culture as a test of cure. This is just to give you a patient care guideline as a flow chart to understand what we need to do in terms of not only diagnosing acute UTI, but also to look for complications. So, take-home message to the audience, screen every pregnancy for asymptomatic bacteriuria. Urine culture still remains the gold standard. Ultrasound to be done if ascending infection suspected. If it is a complicated UTI where you're suspecting a obstructed system or a calculus, a MR urogram is preferable because CT is prone for radiation. Thank you very much.
Hello.
Yes, ma'am.
Mr. Nagashankar, there is some disturbance in the audio. Could you please?
All others I have muted, ma'am, except Meera, ma'am. Everybody is on mute.
There is a lot of disturbance. Please look into it. Perhaps we could, Madam, the chairperson, please. Can you proceed with the next?
Please unmute and then
all the questions will be taken at the end of the session. Questions will be at the end.
Chairperson can unmute and talk.
Hello.
The role of imaging by our own doctor is Dr. Aparna Hegde from Delhi, and she
Mumbai and Delhi, yeah.
Imaging, and she's very, very keen for this topic. And I know the urinary routine or concern, we do not do any imaging unless otherwise there is a suspicion of pyelonephritis. But she has a lot of innovative ideas on this regards. I welcome Dr. Aparna Hegde, madam, to come up the dais and deliver your.
Yeah, thank you so much for this invitation. And my topic will cover all aspects of UTI, not just UTI and pregnancy. And it is basically in complicated UTI. And I do practice the whole spectrum of urinary tract infection treatment. But ma'am wanted me to speak on ultrasound, so thank you, ma'am. Right. So in complicated UTI, of course, everybody has spoken. Dr. Meera Raghavan has really spoken about how in patients who have got UTI. Can you hear me? Yeah. It's very important that you need to do upper tract imaging, a KUB, and look for any kidney changes that you see, or you can see stones. I'm not going to cover those things because everybody knows that, right? I'm not going to show you imaging. So I'm going to show you in complicated UTI what are the other things that you can see on ultrasound, because I have a 5-minute talk, right? So one thing, obviously, one of the complicated UTIs that gynecologists would see is when you have cystocele along with UTI, correct? Because of the fact that you might have retention of urine that leads to it become a culture medium for UTI. Then diverticulum, very important, right? So a small proportion of women, 4%, not really understood exactly the right number because of the fact that a lot of asymptomatic women might have diverticuli, but you do have symptomatic women with recurrent UTI who may be having diverticuli that are missed, right? Because regular ultrasound does not pick them up, and the symptoms can be very vague. Then also when you do sling surgery, you can have mesh erosion, right? And that can also be a source, of UTI. And, when you, especially in prolapse patients, when you put in a sling, right? And there is obstruction, right? Now, when there's obstruction because of the sling, is it because of the, sling itself, or is it a case of pelvic floor dyssynergia? So all of these things are cases that I do see in my practice because I get referred complicated UTI patients, right? So we use the BK Flex Focus machine, which is, and when we do is, what we do is multi-compartment imaging, because when you do multi-compartment imaging, you're able to see the same structures in different planes. So we start off with transperineal ultrasound, 2D and then 3D. And then we do a antipelvic compartment imaging, 2D and 3D. It's a 180 degrees scanning of the antipelvic compartment. The probe is different from the one used for transperineal. And these are all higher frequencies than regular ultrasound. And then we also do a 360-degree scan of the pelvis with a transducer, which is the same one as we use in endoanal ultrasound, right? So I would like to start off with showing you a prolapse. Now, because you do see patients of prolapse with cystocele having retention issues. Now, when they talk about dynamic MRI, unfortunately, is not physiological, right? The patient is not in a sitting posture, whereas in ultrasound, you can see a sitting posture. So what do you do? And it's very important that oftentimes you will not be able to see patients with cystocele very well on regular examination because there can be levator muscle co-activation. So at that point in time, ultrasound helps. So you see here, this is a transperineal ultrasound, 2D dynamic film in the mid-sagittal plane. Okay, so you see the bladder, here, and you see that when I'm asking the patient to bear down, you can see that the cystocele is a recurrent cystocele, right? And this speaks for the fact that the mesh that was put in, this is ProLift put much earlier, and that detached from the apex. The mesh detached from the apex and caused a cystocele. So, and this is a patient in whom the cystocele was not being seen on regular examination because of levator muscle co-activation. Now, diverticulum, right? Now, diverticuli, when you see, it's very important to differentiate it from regular vaginal masses. So, is the diverticulum responsible for the infection or not? Is something important. So, when you do ultrasound, you can see. So, this is a 3D antipelvic compartment cube that you get. You have the probe in the vagina. I'm scanning antipelvic compartment. When you manipulate the tube in the sagittal plane, you see the diverticulum coming into view. And when you go to mid-sagittal plane, you can see the diverticulum is starting from the right. Going in the middle point is actually horseshoe shape. It's actually both anterior and posterior to the urethra. This is the urethra, and this is the diverticulum opening into the urethra. You see this? Here it's opening in, right? And then you can actually manipulate to the other side, the right of the patient. So you can actually get a 360 degrees view. I'm showing you manipulation in the sagittal plane, but you can manipulate the cube in the coronal and the axial plane. You can see the diverticuli every view. So the important thing is to see whether it's opening into the urethra. And that is something that you can see in ultrasound, which you cannot see oftentimes even on MRI. And then you can differentiate that from a regular paraurethral cyst, right? So this is a paraurethral cyst, right? And this is antipelvic compartment imaging, right? The 3D cube, I'm showing you a mid-sagittal plane cut, right? Probe in the vagina, I'm scanning anteriorly, right? And you see the urethra here. And you see the paraurethral cyst here. Now, if you see the paraurethral cyst here, it is not opening into the urethra. And this is clearly not a diverticulum. So this is extremely important to find out, because if it's a diverticulum opening into the urethra, it's extremely important to operate and remove it, right? right? And so when you have mesh erosion, right, so you can look at mesh erosion through cystoscopy, correct? But cystoscopy will only show you that a mesh that is lying inside the bladder. Now, this is anterior pelvic compartment imaging. Again, I've got a 3D cube. I'm showing you mid-sagittal plane cut, right? So probe in the vagina will be here. I will have a probe inside and I'm scanning anteriorly, right? And here what you see is this is a patient post cystoscopy where the mesh which is eroded into the bladder was removed through cystoscopy. Unfortunately, you can't remove all the mesh. So you have to actually do an ultrasound to see where the remaining mesh is. And if you can see clearly here, I'm showing you the bladder. This is bladder, sorry, the spelling mistake, but bladder and the bladder, this is hypoechoic, right? This is urine in the bladder, right? And you can see the antevaginal wall. And can you see the mesh here? This is a whole lining of mesh. Now, this is a TVT that went too close to the bladder and eroded into the bladder. But there is remaining part of the mesh which could not be removed through cystoscopy. So you have to prognosticate and tell the patient that we've removed whatever we could see, but there is a lot of mesh lying and which we can actually erode later on, right? So this patient requires, a periodic assessment to understand is the mesh going to erode in or not. Lastly, sling obstruction, right? So that can also, when you put in a sling, I get patients with sling surgery done and then they end up with overactive bladder later on, or they have obstructive symptoms. Overactive bladder symptoms can be a sign of obstruction. And then they come back with high post-fight residual. So sometimes the sling is obstructing, sometimes sling is not obstructing. How do you make out, right? Urodynamics will not give you a clear picture, right? So here you have, again, antipelvic compartment imaging. And you can see clearly in the antipelvic compartment imaging, this is the bladder, this is the urethra, right? And now can you see the sling here? See the sling here. It's impinging into the urethra. Can you see this? It's impinging into the urethra. And when I ask the patient to see this, right? Properly impinging into the urethra. This is a sling that has to be removed. She is somebody who came back, 6 months after surgery with obstructive symptoms with recurrent UTI, and then this had to be removed because it's clearly obstructing. When I'm asking the patient to bear down, can you see the sling obstructing the urethra? Right? I'm asking the patient to bear down. Again, I'll show you the bearing down. Right? This is a sling, and I'm asking her to bear down. See now, it's pushing the urethra. It's impinging the urethra. This is absolutely obstructive. But I'm going to show you another patient who underwent sling surgery. And 6 years after sling surgery, and she ran upon transoperative sling. It's not even obstructive, right? And she developed obstructive symptoms. Okay, 6 years after surgery. Now, what happened is that, and the point is that she never had obstruction at the time of surgery. 6 years later, what will lead her to develop urgency, frequency, and incomplete bladder emptying? So when we did a urodynamics, it was inconclusive, right? So her peak detrusor pressure at peak flow was 32 centimeter water, which is okay. And her peak flow and mean flow was 5.8 ml per second. But her post-fight residual was 70, right? So though she had a contiguous configuration low flow pattern, it was not very clear what was happening in this patient, right? So when I did an ultrasound in this patient, what did I see, right? Now this is 2D transperineal imaging, right? So this is transperineal mid-sagittal plane cut. So you have the bladder, you have the urethra, you have the symphysis pubis, and you have the vagina, right? And you see the sling here. The sling is proximal mid, right? So look at that. It's okay. I mean, it's around 7 millimeter from the urethral lumen, so it's not too tight, right? And so when I asked the patient to cough, look at how the sling worked, right? So when I asked the patient to cough, it was obstructing the urethra, but not causing kinking. But look at when I asked the patient to do Valsalva, and I'm almost finishing, right? So when I asked the patient to do Valsalva, see what happens. Look at how, when I was asking patient Valsalva, the sling was causing kinking of the urethra. See that again. When the patient was Valsalving, look at this. It's kinking the urethra. So basically what happened is we looked at her, ultrasound, urodynamics, before sling surgery. And what did we find? Remember one thing, many of our patients who have got prolapse have pelvic floor dyssynergia, meaning because of constant prolapse and long-standing prolapse, and because of obstruction, they have developed this very bad habit of pushing down to pee. Right now, because they have to strain to pee. When you have a cystocele that's obstructing, they have to push to pee. Now, when you do surgery, and when you do prolapse surgery along with sling surgery, if you do not take care of this bad habit of pushing down, what can happen? The sling only knows one thing, right? The sling knows how to obstruct, right? When somebody is pushing down, the sling will obstruct. So this is a patient who used to strain to pee. Okay, and the sling surgery was done, but she was not trained to void better. So she continued pushing to pee. And the sling over time started causing obstruction. So you understand, when I asked her to Valsalva, the sling was kinking. So every time she went to pee, she was Valsalving to pee. And that was causing kinking. So in such a patient, and it was very clear in her, micturition study pre-surgery, it was very clear that she was peeing by abdominal strain. And so we trained her how to pee better, and she was, cured. We didn't have to take out the sling in her. So these are very different scenarios in which you need to do ultrasound in addition to a KUB to see the kidneys and for a kidney stone. Thank you.
Thank you, Dr. Aparna. And now it's all about the complication of sling and anterior vaginal and everything. It is so complicated. Now we are scared of putting whenever we decide to put. Now, Madam, our guru, Dr. Raja Maheshwari, will be talking about urolithiasis in pregnancy. We often come across this case during pregnancy and also non-pregnant stage, and it is difficult to treat and it is difficult to counsel the patient also when they get pregnancy. And Madam is going to resolve this problem for us. Thank you, Madam.
Thank you, Uma. Am I audible? Is my slide seen?
Yes, ma'am.
Yes, ma'am. Yes.
You have the slide is seen. Okay, right, right. So, how common is the urolithiasis in pregnancy? It really complicates 1 in 200 to 1 in 2000 pregnancies. So, is it the same? The incidence is the same between non-pregnant and pregnant symptomatic stone? It is almost similar. Initially, it was thought multiparous women were more affected, but when age was adjusted, they found it is not so. And then this is one of the most common cause for abdominal pain requiring hospitalization. And when they compare the left involvement to the right, it is almost the same equal frequency. And what is important is ureteric stones are twice more frequent than renal stone. And 80 to 90% of the patients present in the second or third trimester of pregnancy, very rarely in the first trimester. What happens in pregnancy is, in the pregnancy, 90% they develop the physiological hydroerythronephrosis in the right side and 67% in the left side. And it starts as early as 6 to 10 weeks and resolves by 6 weeks after delivery. It is often difficult to differentiate between physiologic from the pathologic hydroerythronephrosis. We all know that it is a combination of hormonal and mechanical effect that causes the hydroerythronephrosis. What really happens in pregnancy is, during pregnancy, the pH increases. Along with the increased pH, there is also hypercalciuria. So what really happens is this favors the crystallization of calcium phosphate stone. So normally you encounter more number of oxalate stone in the general population, but in pregnancy, you will encounter calcium phosphate stone than oxalate stone. So we have the lithogenic factors in pregnancy. The progesterone is high, urinary stasis is high, GFR is high, and there is increased excretion of calcium, hypercalciuria because there is supplementation as well as increased vitamin D level. The pH increases, and there is also a decrease in the excretion of uric acid, sodium, and oxalate. So countering to this pro factors, there is a concurrent increase in the inhibitors, like increased excretion of magnesium, citrate, glycosaminoglycans, and the decrease in the uric acid production. So the overall prevalence of nephrolithiasis does not increase because of the balance between the lithogenic and inhibitory factors. Next, ladies and gentlemen, normally people present with flank pain, 85 to 100% cases, A microhematuria, not even macro, 95 to 100%, and the acute abdomen features. So the obstetric cases, almost like acute abdomen or resembling placental abruption or PIH with hepatic involvement. In non-obstetrics, of course, you have the appendicitis, cholecystitis, and all. So what are the complications? You know, the preterm labor, which is very important. And we all know that other causes for preterm labor is dehydration, vomiting, and there is a release of ADH and oxytocin, and that will worsen the situation. How are we to evaluate? The first investigation and the most important is ultrasound. Ultrasound screening of the kidney bladder area. You can measure the pelvic diameter. You can use the collar Doppler to look at the efflux. You can measure the resistive index, ureteric jets, and use even the endoluminal ultrasound. And IBU is not recommended. Radionuclide renogram not used. MR urogram becomes the second common. If ultrasound remains inconclusive, then one should resort to MRI. And because it doesn't involve any contrast and there is no ionizing radiation, it can even differentiate whether the dilatation is physiologic or pathologic. But we don't want any CT scan. So if you use the transvaginal and endoluminal ultrasound, somebody as good as Aparna Hegde, we can even pick up the lower ureteric stones using the endoluminal ultrasound. And there's a low-cost CT can be used, and it has a 95% specificity rate. MRI becomes the next option and can pick up even a smaller stone and can differentiate physiologic hydronephrosis from the pathologic. So how are we going to manage? Is it 70 to 80% conservative? Provided the stone is less than 1 centimeter, it is uncomplicated, there is no sepsis, and patient is stable. So what are the conservative measures? The hydration, analgesics, and all these things you can try it. So if you're planning for conservative treatment, the studies say that if the stone is at the UPJ or in the proximal ureter, it is less likely to respond to conservative treatment. One should consider that point when you're planning for the conservative treatment. What about medical expulsive therapy? You know, the alpha blockers, the tamsulosin and other things, but they are right and left freely prescribed in all over. But only thing is, there are reports saying sick infant deaths occurring with the medical expulsive treatment using the tamsulosin and other things. So the safety is under question and it is not recommended. Then, using the citralca, I already told you that sodium alkalizers are not good for 3 reasons. One is you can't mix it with quinolones and you can't use it with hypertensives because of the volume overload. So it's better if you want to use an alkalizer, go ahead and use a potassium alkalizer, which has the least side effects. And this potassium magnesium citrate, which comes, is very effective, and it has many advantages in the sense. This is Professor Charles Pack. This was developed by him for the NASA people, and because the fact that in microgravity there is increase in formation of calcium oxalate and uric acid stone. So this research and his was with that importance, it was evaluated, and they have found out how the potassium magnesium citrate is effective in taking care of preventing the stone recurrence. So what are the stone risk factors? You know, high pH, if you use the alkalizer, citrate level goes up, the magnesium level goes up, uric acid level goes up. So then the saturation of the calcium oxalate gets decreased. Then what about the active treatment? If your patient has infection, conservative treatment failed, or if it is a case of solitary kidney or patient with acute renal failure, then you have to resort to active management. active management can be divided into temporizing and definitive treatment. In temporizing, you have the stenting and the percutaneous nephrostomy steps. And in the definitive, you have the ureteroscopic stone removal of the ureteric stones. So the temporizing options is very good if the conservative treatment fails, or if it is of complex anatomy, or there are obstetric concerns, or patients present to you either very early or very late in pregnancy. Temporarily, you can put in the stents, which has to be replaced every 6 weeks. And then in the active management and the PCNL, the percutaneous nephrolithotomy, it is not advocated, but it is not an absolute contraindication. ESWL, extracorporeal shockwave lithotripsy, should not be offered. And ureteroscopic stone removal is an acceptable one, provided you don't have the endourological setup. And when patient is symptomatic and septic, if you don't have access to ureteroscopic removal, one should consider the open surgery. So ureteroscopic, up to 80% of the stones can be removed with low complication rate. So that is the obstetric complication rate is also much less with the ureteroscopic stone removal. See the advantage, there is already dilatation of the ureters because of the pregnancy, high progesterone. You need have to use fluoroscope. You can even do it under local or selected anesthesia. And disadvantage, very, very rarely one can encounter perforation or infection. So using ureteroscope, certainly you can use the laser, or you can even use the lithotripsy. So ureteroscope should not be used if the stone is bigger than 1 centimeter, if there are multiple stones, if it is a transplanted kidney, or if the patient has sepsis, or if the endourology setup is not adequate. Ladies and gentlemen, I would like to take you to the 2 decades ago. In those days, the old practice was, we will just see if there is a stone in a pregnant woman, see whether there is infection or no infection. If there is no sepsis, we will observe her and evaluate and treat her only after delivery. If there is sepsis, depending upon whether it is in the first, second trimester or third trimester, we will plan the treatment. If it is nearer term, we will go and induce labor. If it's not near term, we will use the stent or PCN. Similarly, in the first and second trimester, if it is less than 1 centimeter, we will go ahead and do a PCN or the ureteroscope stenting. So this is how the practice was there earlier. But you see the paradigm shift in the active management of urolithiasis. Now we have temporizing the schedule and definitive schedule. So you need to discreetly use it into clinical practice. Ladies and gentlemen, I would conclude by saying, see, diagnostic and therapeutic challenges are common with nephrolithiasis in pregnancy. Ultrasound remains the mainstay. Conservative treatment should be the initial option. Temporizing and definitive schedule can be planned based on your discretion if conservative treatment fails. In ureteroscopic stone removal, it is advocated you do it in the second trimester, not in the first trimester, not in the late trimester. If you want to use alkalizers for conservative treatment, please use the potassium alkalizers and not the sodium alkalizer. Ladies and gentlemen, we have a survey and a questionnaire. The link will be provided. Please make sure that you participate in it. Thank you very much.
Thank you, ma'am. Dr. Uma, I am taking the opportunity. Dr. Uma, I am taking the opportunity to thank Dr. Raja Maheshwari. It is excellent, really. I am with the whole team for the last 2 hours almost. But what is unique in Madam is she focuses on very uncommon part of a very common topic. And really as you have rightly told, Uma rightly told, that many of us would not be on the platform of urogynecology if Madam was not there. Because Madam is the motivator,
Definitely.
she is our philosopher, guide, and
Yes,
she has taken us
agree with
and
you, Dr.
focused
Biswas.
all the urogynecologists of Asian countries to the highest level. So
Yes,
we want to see her
definitely.
at the
She's
top of the
yes.
organization on one
She
day.
should. We should
Yeah,
have voted for her as Vice President Ayuga.
yeah.
I hope everybody has
Yes,
voted
ma'am.
for her.
Yeah,
Yes,
yeah.
yes.
Very good
Now
presentation.
now
Very
we
good
welcome
presentation.
Dr. Lily Varghese. Dr. Lily Varghese from CMC Vellore, and we have all learned together. Lily, we remember you, and you've risen to great heights with your research. So welcome, Lily, regarding antibiotics for urinary tract infection in pregnancy. You've privately given me an answer to my query of whether we should combine two antibiotics, and thank you. Please, the slides are yours, and start your talk. Thank you very much.
Thank you, Dr. Shama, for your kind introduction. My greetings to Dr. Rajamaheshwari, Madam. Thank you very much to all the chairpersons, friends, colleagues, and attendees. I'm going to dive directly into this very important topic because very often we think, I hope my slide sharing is visible and I'm audible. And I jump into the topic straight because very often we equate antibiotics as the only treatment. But however, I'd like to say we should take a holistic view of the whole scenario. Antibiotics is one part of the treatment, and all other measures should include to have a favorable outcome. Now, as we saw, there are just three main clinical scenarios. There's asymptomatic bacteriuria, which unlike other circumstances, we have to treat in pregnancy. So pregnancy is a special circumstance, though it's not complicated, it's a special circumstance. So you have asymptomatic bacteriuria, you have cystitis where the infection remains restricted to the lower urinary tract, and of course an ascending and more dangerous form called pyelonephritis. The goals of pharmacotherapy and antimicrobials is to eradicate infection and thereby reduce the morbidity and prevent the complications that can result from untreated infection, urinary tract infection and pregnancy. Now, almost all antibiotics being used, I'm going to address only antibiotics, are all category B drugs. Very rarely would you go to a category C drug. We know there is an FDA category system. No antibiotic falls in category A. Majority are in category B, very few in category C, which would come as the second line drugs, and definitely not those in category D, because we are treating two people, the mother and the baby, and also indirectly the community. Now, we all know without question that penicillins are a very safe group of drugs. However, without the inhibitors, we know that the penicillins are very prone to developing resistance. There's resistance in the community. The next group of drugs is cephalosporins. Of course, monobactam, aztreonam is very effective, particularly in gram-negative infections. Fosfomycin is not a new kid on the block, is the old kid which has been resurrected and brought back on the block. Fosfomycin was used before, went into disuse, and has been brought back because of multi-drug resistance in the bacteria that we are now seeing. And of course, nitrofurantoin. Nitrofurantoin is advocated by most groups. However, of late, the American College of Obstetrics and Gynecology, the ACOG and the CDC, particularly from America, have raised a question mark on using nitrofurantoin in the first trimester and in the third trimester. We'll come more to that later. Parenteral beta-lactams are mostly reserved for severe pyelonephritis. By beta-lactams, I mean whether the advanced generation of cephalosporins or whether you're talking about drugs such as meropenem and the other entire group of drugs, the imipenem. Imipenem, of course, is not advised. Piperacillin, tazobactam. The other carbapenems, meropenem, atrapenem, and doripenem. Imipenem silastin is not advocated because they have found that in some animal experiments, they have found to be complications, particularly with pregnancy. Okay, so, but we have teratogenic concerns because we're dealing with a baby, particularly up to 16 weeks when there's organogenesis going on. But even after 16 weeks, there can be subtle problems, particularly with the ears, with the olfactory system, and with the CNS. So always concern teratogenic issues should be on the top of the mind of a person treating a woman in pregnancy. Fluoroquinolones are definitely out because of its arthropathy, tetracyclines because of its effect on bone and teeth, and of course sulfonamides again is considered a teratogenic drug. The combination trimethoprim sulfamethoxazole, though very effective, should be avoided in the first trimester. The reason being that it acts as a dihydrotetrafolate reductase inhibitor, and folate sensitive birth defects like CNS defects, cardiac defects, etc. are known to occur, mostly in animal experiments. And in second trimester, it's a safe drug. However, more than 32 weeks of gestational age, it very firmly binds and therefore displaces bilirubin into the circulation and can result in kernicterus in the baby if it is given after 32 weeks of gestation. Ceftriaxone again is one of the drugs which should not be used, cephalosporins, which should be avoided, particularly in the peripartum period. Can be used in the third trimester, but avoid it in the peripartum period. Parenteral beta-lactams are almost all safe in pregnancy, but avoid imipenem and the silastin combination. Now, nitrofurantoin, particularly as I said, CDC and the ACOG, have said that you need to have a trimester-specific approach. In the first trimester, it is preferably avoided because it can result in some subtle abnormalities, congenital abnormalities. And in the third term, particularly, even the trimethoprim sulfamethoxazole combination should be avoided because in people who are G6PD carriers, and we know it's an X-linked disorder, so that the male fetus may end up with hemolytic anemia because the mother is usually a carrier. Aminoglycosides can be used, but however, you should remember it's a category C drug, and ototoxicity can occur with prolonged exposure. So it's not usually used as a first-line drug. Now, asymptomatic bacteria should always be treated in pregnancy. The reason being, about 30 to 40% of these individuals can go on to have a full-fledged pyelonephritis or have a symptomatic cystitis, which can have sequelae for the fetus. So you can have a preterm birth and all the problems resulting from a preterm birth, including low birth weight is known to be associated and many other conditions. Always consider when you're treating asymptomatic bacteriuria, particularly if you detect it in the first trimester, did this woman have repeated urinary tract infections even before pregnancy? Has she been treated with any antibiotics? Is she resistant? So always in asymptomatic bacteriuria, as the patient is not symptomatic, there is no hurry to treat her. Await urine culture and sensitivity results before initiating treatment. Or oral antibiotics can be administered in this group of patients based only on the sensitivity pattern. Also, understanding the local sensitivity and the antibiogram of your hospital helps. Acute cystitis. Now, the next step where you have a symptomatic infection, the antibiotic treatment of choice is oral because the patient is symptomatic. It's initiated empirically after asking the patient to give a culture and sensitivity, and the treatment is subsequently tailored to the susceptibility of the antibiotic based on the culture and sensitivity results. The test of cure is a follow-up culture and should be done in every single pregnant patient to make sure you have eradicated the bacteria. And this follow-up culture and sensitivity is usually done between 1 to 2 weeks after treatment to make sure that you have eradicated the bacteria. Now, treatment failure and relapses may need to be treated with a different antimicrobial for a longer period of time. And if there is persistence or recurrent relapses, then one need to think in terms of ruling out underlying pathology. So I have bunched up both these groups, that is asymptomatic bacteriuria and symptomatic cystitis together. For all these groups of patients, it's preferable to give at least a 5 to 7 day course of the antibiotic. The course is usually antibiotic specific, but in a generalization can be made, saying in general, give it at least for 5 to 7 days. Nitrofurantoin, the macrocrystals are usually given 100 mg orally for twice daily for 5 to 7 days. And amoxicillin clavulanate, what we commonly goes by the trade name of Augmentin, can be given 625 is given 3 times daily or 8 hourly, and the 1 gram can be given twice daily. Cephalexin and amoxicillin are less preferred drugs because of rampant drug resistance by the bacteria, which are usually E. coli in the majority of the circumstances. Phosphomycin, available locally in a sachet, can be given 3 grams, can be given as a single dose with water, but it's also available as an IV preparation. And drugs like phosphomycin and nitrofurantoin concentrate in the urine. As we heard Dr. Hemant speaking and giving an excellent capsule, a summary of antibiotics. Most of these drugs are secreted into the urinary tract, and there is very less tissue penetrance. So we are aiming at eradicating the bacteria within the urinary tract of the woman. Now, should you give a single starch dose, a 1-day treatment, a 3-day treatment, or a 7-day course? Guidance is not very clear. However, it is said that single dose may be less effective, and it is preferable to give 4 to 7 days treatment at least. Single dose treatments with cefalexin, trimethoprim, sulfamethoxazole, amoxicillin shows a cure rate of only about 70%. So asymptomatic bacteriuria and cystitis should be treated with a standard regimen. Acute pyelonephritis is a different cup of tea. We know now it has penetrated into the tissue. It is causing systemic symptoms. The mother can decompensate very rapidly, can develop respiratory symptoms. It can have significant sequelae on the baby. The baby can also have a bloodborne infection. Therefore, you treat this very differently. While the other two groups can be treated on an outpatient basis, the minute the lady has flank pain or severe fever, chills and rigors, and you know it is in the bloodstream, it's preferable to initiate inpatient treatment with IV antibiotics. Always IV in the initial 24 to 48 hours. In the meantime, you send a urine culture sensitivity before initiating the antibiotics. You wait for the results. In most cases, we also send a blood culture sensitivity. The treatment is always started empirically. It is parenteral. And in most cases, you end up giving a broad spectrum beta-lactam in the present day circumstances where you encounter a lot of drug resistance. So once a woman is afebrile for 48 hours, you can shift to oral therapy based on the culture and sensitivity results. You require a total duration of treatment of at least 10 to 14 days. If there's inadequate response in 24 to 48 days, we have to reassess the woman, maybe with a repeat urine culture and a renal ultrasound to rule out other pathologies. And all these women with acute pyelonephritis, you need to consider prophylaxis for the remainder of pregnancy. I did not think it was wise to reinvent the wheel. So I just put up this chart from Up to Date by Thomas M. Hattoon, etc., who has done a lot of work on pyelonephritis and UTI in pregnancy, which gives the dosages of the various beta-lactam drugs, the monolactam, which is aztreonam, ampicillin, gentamicin, all the doses are given in this, and this is a very excellent chart. You can go by this. In many cases where we cannot give repeated dosing and we are continuing with intravenous administration even on an outpatient basis, we personally shift to ertapenem, which is a once daily dosage. Antibiotic prophylaxis in cases of recurrent urinary tract infection can either be daily or postcoital. Again, guidance is not very clear and the advice is not very definitive. The indications are usually in those cases where there's a pre-pregnancy history of UTI. And
Hello? Hello?
We don't see her slides.
Hello, please, Mr. Nagashankar, please let Lily Madam complete. Hello?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Some connectivity issue, ma'am. It got.
Okay. Lily, can you hear us?
I think Madam has to unmute herself.
Lily, you have been muted.
Yes, ma'am. I've unmuted, ma'am. Can you hear me?
Yeah.
Hello, ma'am.
Can you hear us, Lily?
Yes, ma'am. Can you hear me, ma'am?
Yeah. Please go ahead.
Okay. So persistent UTI, asymptomatic bacteriuria, and if there is a one episode of
Yeah,
UTI,
your slide is not moving. You are in antibiotic prophylaxis recurrences state. Yeah, okay. Yes.
so the regime for prophylaxis is usually nitrofurantoin, 50 mg and 100 mg doses have both been advised. Cefalexin, 250 to 500 mg. Also amoxicillin can be used. The treatment success is the clinical outcome. The aim is the eradication of bacteria rather than the duration of treatment. So we should not obsess on the duration of treatment. It's the clinical outcome. A test for cure is urine culture sensitivity, which should show negative findings 1 to 2 weeks after completion of therapy. A non-negative culture result is an indication for a prolonged course of antibiotic, maybe of a different group. So antibiotic, antimicrobial stewardship is very important. Remember, as CDC says, you're treating for 2 people, and always consider the use of the safest antibiotic for the right indication, the right dose, and the right duration. It is very important, and I would like to re-emphasize culture sensitivity is the mainstay and the gold standard for treatment. And the aim is to give the baby to have a healthy mother and a healthy baby. Thank you very much. Thank you, madam.
Hello.
Lily, I think Uma, you should invite the next speaker.
Yeah, madam. Yes, madam. Yes, just a minute.
Yeah, please request Srikala, madam.
Yeah. And now our topic is on conservative versus interventional treatment by Dr. Professor Srikala Prasad. And we also, yes, it's a very respectable position, and also she is one of our best guide and mentor so far as we see Chennai is having. Chennai is lot of urogynecologists and sincerity, and we really hats up to Chennai, the soil of Chennai. And now Dr. Sikala is for this topic, madam. Just start your topic.
Thank you, Uma, for the nice words of introduction. At the outset, I would like to thank Professor Rajameshwari Madam for giving me this opportunity to talk in this August audience. Respected senior members, my colleagues, and my most dear postgraduates, good evening to one and all. The topic today given to me is conservative versus interventional treatment. So we have from 4 o'clock, we have heard a lot about the hygiene, frequency, timing of voiding, wiping patterns, the hot tubs, type of undergarments, all that. Prevention of constipation will also be a great usefulness in the treatment of urinary tract infection. We have also heard a lot about conservative measures, the self-start intermittent therapy, the post-intercourse prophylaxis, other strategies, and Canberry juice. All that we know. But what is very important is now, as treating obstetricians, we should know what to do. For treating a normal urinary tract infection, all of us would be doing a very good job. But in case we treat and the patient doesn't become all right, say the fever continues beyond 72 hours, what should we do? The simplest, the quickest, least expensive method, and it is available all over India also, is the ultrasound. It should be the standard initial study in our pregnant population. And if the patient's fever doesn't settle by 72 hours, like we have to think of so many things where we're not giving the correct antibiotic, which was responsive to treatment. Because when they come with fever, we are going to start them on a empirical course of antibiotic. We have to think whether we need to change the antibiotic based on the culture, because by then the culture would have come. But what is very important is we should rule out other causes, like, for example, acute focal and multifocal bacterial nephritis, renal abscess, The infection has sort of settled and has formed an abscess. So you have to drain that. Unless you drain that, it's not going to become all right. The second thing, Madam was talking about emphysematous cystitis and pyelonephritis. What we need to know is a life-threatening infection, which is diagnosed radiographically by the presence of gas in the parenchyma or the pelvic ileal system. This is a really life-threatening indication. So you have to give a real good treatment and surgical management, whether it is a stenting, say, strong antibiotics. Sometimes it may land up even in a nephrectomy. And hydronephrosis, whether it is infected hydronephrosis or pyonephrosis. Here, what all the obstetricians always feel is, we know that pregnancy is associated with physiological hydroureteronephrosis more on the right side. So when you do an ultrasound and you see a hydronephrosis, you're worried. You're worried whether there is a problem or is it normal. So we will look into that. And if it is an infected hydronephrosis, we have to drain it. Pyonephrosis is a more serious term. That means almost we have, that kidney is a kind of, we have disowned. It is not going to function any longer. Or it's a perinephric abscess. So the most important test would be an ultrasound. And we'll also talk about, generally we don't do a CT scan because we get a lot of information in a well taken ultrasound and we are worried about the radiation hazards. What I wanted to re-emphasize to the people who are listening is, so far as urinary tract infection is concerned, we know about the preventive measures, we know the conservative measures, we know the treatment, all of us are extremely good. What we need to know is this urinary tract infection, when associated with obstruction, it's a deadly love affair. It can be a killer disease. So this obstruction plus infection is a true urologic emergency that can potentially lead to urosepsis, gram-negative septicemia, perinephric abscess formation, or even death in pregnant women. I do understand this is not a common scenario in our routine pregnant patients, but we must pick up even the rare cases who come to us. For example, fever, rigor, loin pain, tenderness, they are all markers to say that there is something wrong which we need to take care. And this, and generally this kind of an infection, Lily also was highlighting and Madam was highlighting. So hospitalization, IV fluids and antibiotics are definitely the role. An obstructed kidney has difficulty concentrating and excreting the antimicrobials. So remember, obstruction and infection is a deadly love affair, a killer disease. So any substantial obstruction must be relieved expediently by the simplest method. So Madam, when Madam was talking about stone diseases, she was talking about all the measures, like for example, PCN, lithotripsy, all that. Not only stone disease, any obstruction, it can be, it's not common, but can occur. A diabetic patient, a slough papilla can come and get obstructed. If that obstructed system also gets infected, then we have to relieve the obstruction. So an ultrasound is very important to diagnose whether there is obstruction. So how will you diagnose infection? So at the end of this talk, if you remember that if the infection is not getting under control, we need to find out what has gone wrong and how to save the mother. And next is the baby. But the mother is our number one criteria. So ultrasound, we need to differentiate a normal hydroureteronephrosis associated with pregnancy from a obstruction. We know because of the dextrorotation, the right side is more commonly dilated, but this dilatation in pregnancy can be because of the mechanical obstruction by the gravid uterus or because of the hormonal effects. But if we have studied patients who have had the ureters outside, then they say that there is no dilatation. So it is more often because of the mechanical obstruction. A transvaginal ultrasound is also useful in imaging a distal ureter. And color Doppler. In this color Doppler, we can differentiate iliac vessels from the dilated ureter. You see a linear tubular structure. You want to know if it's a dilated ureter, it's just a blood vessel, you put in a Doppler. And another easy thing is presence of urethral jets. The right side, the patient is having pain. You are seeing a dilatation. There is pain also. So what is in your mind? You want to know whether you have to stent the patient, whether you have to do PCN, whether is it that dangerous combination which I was saying, no, infection and obstruction. Is it that or not is your worry. But in case you do a Doppler and you're able to see the ureteric jet on that side, then you know it is not an obstruction. You don't need to surgically treat them right now. You have to cover them with antibiotic well. And the other thing is, by doing Doppler, you can do the resistive index. The resistive index is not altered during pregnancy. There is no change in the physiological dilatation. So if you see the resistive index is increased, it's an evidence of obstruction. But only thing is, it is useful in acute cases. So to know whether there is obstruction or is it just dilatation, simple things like a Doppler, look for ureteric jet, and then maybe a resistive index. Then next, MR urogram. MR urogram does not rely on ionizing radiation, but will identify the area of obstruction as signal void. Then I was talking to you that gram neck infection obstruction is a dangerous combination. So here the life of the patient is more at risk. Can we take an IVU? We generally don't take an IVU, but in case the treating obstetrician and the urologist feels there is no other go, we can do a limited IVU, doing 1 scout and 1 30-minute after injection of contrast. And each film exposes the fetus only for 0.2 to 0.2 rads, which is well below the threshold. And to our relief, we have low dose CT protocols now. The ideal teaching, remember, we don't do CT in pregnancy. We mainly stick on to ultrasound. But in case we are having doubts, we can do a low dose CT. Even a low dose CT has helped in various studies in reducing a negative ureteroscopy. Pregnant women, we are worried about doing a procedure. At the same time, we don't want to avoid a procedure which is indicated. So you can do a low dose CT protocol, which will identify whether there is obstruction or not. So you have identified obstruction. I told you again, infection and obstruction, dangerous combination. What are we going to do? You should arrange for an ultrasound guided drainage of the renal or the perinephric abscess with a pigtail drainage. Can be done in the bedside, no need of contrast, no need of anesthesia. And similarly, if there is an infected hydronephrosis or pyonephrosis, you can just put in a PCN and that will drain. If there is an obstruction, take it from me, a kidney, the ureter which is obstructed will lead on to a compromised renal function. The longer the renal unit is obstructed, the more will be the renal damage. So if there is a renal obstruction, we need to manage. And if that cannot be done by any of them, we can do a ureteroscopic management of the obstruction and do a DJ stenting. That is, it can be done under regional anesthesia, and we avoid hypotension and do put them on the safe antibiotics. Only thing is, we know that there is an accelerated stent encrustation, so more frequent stent changes may be advised. But last
it's time for next session, ma'am.
That's all over. Nephrectomy may be life-saving in cases of failure of response to intensive medical management, DJ stenting, drainage of kidney in cases of emphysematous pyelonephritis. All these, if they don't respond to our treatment. Thank you, madam. Thanks for the opportunity.
Thank you, Madam Srikala, for this very simple and clear funda on the diagnosis and management of this imaging and management. Then I welcome Dr. Amita Jain from Vedanta Medicity from Delhi, and she is a bright academician and a prolific speaker, and has a very strong hold on her own field. So she loves to share her all experience all the times, and she's a very helping person, both in professionally and personally. I welcome Dr. Amita again to deliver your lecture. Dr. Amita.
Hello, can you hear me?
Yeah, you are there.
We can.
So able to see my slides as well?
Yeah, everything is there.
So, by this time you must all have got exhausted a lot, and there was immense knowledge you have received by now. So, most of the things have already been actually covered. I'm just going to revise the things in a very short and crisp manner. So, for prevention, I'm not able to. Okay, so why we need prevention? We have to prevent actually UTI. Why? Because it can have dire consequences in fetus, not only in the form of fetal death. Even in the infant, you can find developmental delay or cerebral palsy, and of course, it has consequences in mother as well. It can mostly pyelonephritis uncomplicated will have no sequelae, but if complicated one, it can cause deterioration in renal function, renal failure, septicemia, and even preterm labor. So, as the various speakers have already mentioned, that asymptomatic bacteria in pregnant women is actually require attention, and it should be evaluated at least at the 12 to 6 weeks of gestation, or if a lady is not very regular with her antenatal visit, for anytime she is coming after 12 to 6 weeks, she should be evaluated. Usually it is done by a single culture test, but it has been seen that there are many false positive results up to 80%. Then a few setups practice to do a repeat culture after 1 week. And if both the culture are positive, then you have to treat these patients. And the treatment, after doing the treatment, you have to repeat the urine culture, because there are chances of recurrent infection in 1/3 of the patient. So repeat culture at 1 to 2 weeks interval, and then it should be repeated once a month if a patient is having asymptomatic bacteria. And if it is persistent, the duration of antibiotics should be longer, or if you can choose another antibiotic from the susceptible. And if there is again, even after that, the repeated culture are showing positive results, and if there is a presence of any additional risk factor, or if a patient is having history of recurrent UTI before pregnancy, these are the patients for candidates for the consideration of antibiotic prophylaxis. Already many speakers have covered all these risk factors. I just need to mention few things like if patient is having this active sexual activity, or patient maternal age is high, anatomical urinary tract abnormalities, especially to mention the vesico-ureteric reflux. If it is congenital one, usually it is asymptomatic, and it is only detected at the time of first pregnancy. Because of the anatomical changes in pregnancy, the reflux increases, and then it can cause problems like pyelonephritis. The sickle cell disease, we all know there is abnormal vasculature of the renal system, and because of that, there would be decrease or deterioration in the concentrating and acidifying quality of nephrons. So all these things causes alkaline urine and the patient prone. Even the immunosuppression, this like patients of transplant, we are having, I'm working with urology department, so many patients of renal transplant and all, they all are require regular screening. There is a complete lecture regarding behavioral and personal hygiene. Yes, all the things are important. And actually, as obstetrician, this is the take-home message for the obstetrician. Apart from all antenatal advice, there should be advice regarding that also, that is prevention of UTI. Adequate drinking, very, very important, and it should be in the distributed form, because there should be a regular supply of liquids to avoid stagnation. Patients shouldn't be like that to avoid just public toilet. They think that just using public toilets, they can catch infection, and they are not drinking for long hours. Stagnancy actually causes bacteria to have time for getting adherent to the wall of urinary system, and on voiding, they will not flush off, and because of that, there would be chances of higher infection. Regular voiding is important, and also the postcoital urination. Everything has been covered by the previous speaker. All these things has to be taken care by the pregnant patient. And if all these things are not working and patient is still having positive results, these are the patient for the candidate of antibiotic prophylaxis. Everything is very nicely covered. Only one thing I need to mention here, that you should not choose that antibiotic which has been given for the treatment part. It's better to choose a different antibiotic from the susceptibility result. That would be a better thing. Otherwise, everybody knows that nitrofurantoin can be given in the form of 50 to 100 milligram, but it should be stopped in the third trimester because of the chances of neonatal hemolysis. So if there is a very strong association with sexual activity, yes, you can decrease the load of antibiotic by just giving the postcoital prophylaxis. Rest of the women should be given antibiotic prophylaxis, that is the single dose antibiotic till the end of the pregnancy. Yes, if you are giving the antibiotic, culture should be repeated at least at the start of third trimester. And if the bacteria is present, then probably you have to change the antibiotic from the susceptibility result. Consider the post-delivery follow-up. Yes, if a patient is having persistent bacteriuria and in positive culture results, these patients need to be evaluated. Everybody has, previous speakers have elaborated what could be the conditions. You have to rule out all the things, stones or reflux, everything through ultrasound and other radiological investigation. Yes, you have to see the risk of long-term antibiotic use and even the complications. These patients might have developed the infection with Clostridium difficile, that is the chronic diarrhea, and all these things, even the resistance with the antibiotics. So all these things should be taken care of. And last to mention, yes, these things can have, though evidences are not strong, these things can have a kind of prophylactic role if you consider the post-delivery self-care in these patients. Thank you so much. This was the short cover of prevention. And
hello.
That was the last. And yes, ma'am.
And Amita, that was an excellent presentation. I would like to say that yours, Srikala's, Aparna's, Meera, JB Sharma, everybody did a fantastic job. We really enjoyed all your presentations. Before taking the questions, I have a small request to you all. Please, do you see the slides? Slide share. Hello? Do you have the slides?
No, ma'am.
No, ma'am, we couldn't see.
Yeah. Do you have it now?
Now we are. Yeah.
Yes,
Yeah.
ma'am. Yes,
Okay. There is a small request from my side. We all know that data is power, and we lack data with reference to the basic problems. And we will be sending you a link, and this will be the link. Please,
sent, ma'am, already.
Please spend few minutes to participate in this. Thank you very much, and I'm handing over to the chairpersons. They will discuss further and take the questions.
Good.
Hello.
Hello.
Good evening, ma'am.
Persons.
Rajivam Vijay here. I'm sorry, my net was not working properly, ma'am.
Hello, Vijaya. Welcome. Please
Yes,
join
ma'am.
join the
Yes,
panel.
ma'am.
Yeah,
Yes,
yeah.
ma'am.
Please
Yes,
join.
ma'am.
And
Thank you, ma'am.
yeah. Hello.
Hello, ma'am. One question to Dr. JB.
Okay.
Yes, sir.
Dr. JB, myself, yeah. Sir,
Hi,
actually,
Dr. Viswas. How are you?
Hello, yeah. I have got one study even doing by my PGT that asymptomatic bacteriuria in pregnancy and its consequences. Yes, I agree with you. It is as high as 11% in my institute. But the question I had to face in the ethics committee that if you do it very frequently, say for example, up to 12 to 16 weeks you have done it, then again in the second trimester, again in the third trimester. So do you offer antibiotics, antimicrobials every time? That question I had to face, or should be the answer actually. How frequently it should be done, and how frequently we should offer the antimicrobials?
Okay. Sir, at AIMS, we are doing it only in the first visit, 12 to 14 weeks of pregnancy, and later on only if they have any symptoms. But if it comes out to be positive, we treat them. You have to treat asymptomatic bacteria. So maybe even if you are doing it in the second trimester again or third trimester, and if it comes to be positive, you have to treat it. You can treat it with a single dose therapy, like I give them phosphomycin 3 grams essay is safe in pregnancy. So, but if it is positive, you have to treat it. I think Dr. Raja Maheshwari will agree with me.
Yeah, yes, yeah. I think the teaching is if after treatment, if the culture persistent, shows persistent positive growth, and then we may have to continue the prophylaxis till it gets negative or till the delivery.
Or till that.
So,
Absolutely.
yeah. Amita wants to add.
Sir, the clear thing is that if on first visit you are doing the culture for asymptomatic bacteria and it is negative, then you don't have to screen these patients later on. But if
it is positive,
if it is positive, then you have to do a periodic screening. That is every trimester you have to do that. That's the clear message. Only in those patients where risk factors are there, even then if there is negative culture with a asymptomatic bacteria or a negative asymptomatic bacteria, those patients with risk factors should be evaluated every trimester or even preferably every month. So only with the additional risk factors. That's all.
Okay.
Absolutely.
So the bottom line is never ignore asymptomatic bacteria in pregnancy. I think Gauri wants to add something. Anybody wants to add?
No, madam, I want to add
Meera?
that if there is repeated urinary tract infection, a low dose nitrofurantoin or cephalexin or even amoxicillin should be given till the end of pregnancy and 2 weeks after, without need for any culture later on if she's asymptomatic.
If the culture is persistently positive, you need to continue the antibiotic, madam.
Yes, low dose.
Yes. One more thing, if the screening shows that there is a group B streptococcus, or if it is a group B streptococcus UTI, the UTI in that pregnancy should be treated and the patient should be given penicillin prophylaxis during the delivery time. Otherwise, there can be a feature of group B streptococcal neonatal septicemia in the form of meningitis.
Yes, even
this is
IUD,
something for
even IUD can
attendees.
occur. Yes.
Yes. In the
Are
form
you
of
actually,
IV penicillin.
Very, very important.
Are you seeing actually GBS in India? I mean, it's very rare in India, they say. Dr. Raja Maheshwaran?
Occasionally, yes. Occasionally,
We
yes.
do
And
see,
it is
sir.
a treacherous one.
We do
one.
see, sir, but we have to be careful about it.
Ma'am, we do see it. This is Lily here. We do see it in pregnancy, and sometimes it also grows in the urine, even though they're not symptomatic. They have to be treated because neonatal sequelae are significant. But we do not have to do a routine smear of the vagina to check.
We don't do the screening.
But if it does come up, you have to treat it.
Very important.
Accepted. Okay. Any more questions?
Yes, ma'am. With your permission, one very simple question what comes in my mind. All learned gatherings are there. In cesarean section, do you, all of you, go for routine catheterization? And if it is so, then keep it there for 24 hours or so. In that case, does it increase the incidence of UTI or we should avoid it?
See, if you put a catheter, then there is a risk of infection.
Yes, ma'am.
But if you're going to do cesarean section under regional anesthesia, then you need to keep the catheter. So you take the risk of, you undertake the risk of infection rather than allowing the patient to go in for a distended urinary bladder and neurovesical dysfunction later on. So I think it is recommended that we keep the catheter.
Neuropraxia itself will lead
Otherwise
on to
also.
infection. So this is a better risk than neuropraxia.
Of the two, which one you will choose?
Yeah, neither nor these.
Full aseptic precautions. I don't
And
think.
otherwise also, sir, as madam said, we do it under regional anesthesia and the anesthetist allowed to give 1 or 1.5 liter of fluid before they put spinal. So the patient's bladder becomes very full, and if you do without, if you don't do catheterization, there is a risk of injury also and
during surgery.
Yeah. And I worked in a hospital. I worked in a hospital where they did not do catheterization and post-op. So whole the round I used to be on that. Madam, bed number 5 has passed urine. Bed number 6 we are putting catheter. Bed number 7 we have switched on the tap and she's not passing. I mean, whole evening was just after the bladder and catheterization and urine. So I feel we leave it for 24 hours and we you can.
I think catheterization in a sterile condition for 24 hours is not going to cause the increased risk of infection. Well, rather it is going to help patients. I don't.
Professor Sharma, I'm glad that you were that keen person who was after the bladder and postpartum care, because that is the most neglected and the most horrendous for the woman as well as the consultant.
Yes, no, it's very, very important. But
absolutely,
we do encounter patients with neurogenically paralyzed bladder coming to us after cesarean section or after surgeries under anesthesia, and having excluded all other factors, and then we are forced to consider the possibility of patient developing a distended bladder after surgery. Particularly with epidural, people do epidural analgesia, you know, so that everybody is happy and contented till the baby is born, and once the baby is born, everybody will disappear. And with the epidural, the mother, she will not regain the sensation of full bladder. So that is one of the cause. I think we need to remember it and take
even
action.
after vaginal delivery, especially prolonged or incidental delivery, this can happen. And so one has to be careful even after normal delivery.
Yes, ma'am. And that is usually due to a perineal hematoma.
Yes.
Because that's where we were taught in PGI. The postnatal people look at the perineum if she's not voided. Because that is something very, very important. I'm sure Dr. Biswas would agree.
Yes, yes, absolutely. I agree with you.
The pain and all the things.
Yeah, when I had a patient who had episiotomy. She was delivered in Middle East somewhere, and then she came to India on 4th or 5th or 6th day. And then when she was catheterized, she wouldn't. Whenever we removed the catheter, she wouldn't pass urine. So ultimately, she was referred to me. It was almost 6th or 7th day after normal delivery. We examined, no hematoma, nothing. And but whenever I removed the catheter again, she wouldn't pass urine. So I had to keep the catheter in and out for almost 3 weeks. Gave her a good course of antibiotic and anti-inflammatory. I gave her this Bidanzin for serexopeptidase and all that, and I was not knowing what to do. And in the end, ultimately, after 21 days or so, somehow she was able to pass urine. I don't know, Dr. Adam Maheshwari, you want to add something to such cases?
Yeah, I think it's a kind of neurovesical disturbance. I think that is very common. You rarely encounter. If you get a patient, certainly we are accountable, and we are bound to manage them. There are many occasions we have to exclude all other possibilities. Then sometimes we can even put her on uricolin and other supportive measures. Srikala, would you like to add anything?
This postnatal voiding dysfunction is definitely a very important point. Not only not able to pass urine, I have seen a lot of patients having totally that infected urine has become pus with a lot of back pressure changes. They're almost going up to elevated the renal parameters. So I always wanted our people to have a look at the amount of urine they are passing. Not only the patient, the doctor, the attenders, we need to tell them the amount, follow up after the catheter is removed or after delivery, a proper trial of void, and that must be maintained so that we will not have any of these problems.
The very important is when we remove the catheter, we don't bother to check whether she has completely voided after the removal of catheter. So normally, if you are tuned to that, if you have an ultrasound machine and check the post-void residue, and then you decide whether further how you can plan the further course, that would be very important, because ultrasound will be available almost in every ward, including the postnatal wards. So I think if you are ever doing a trial removal, please make it a point to residue check the PVR with ultrasound, make sure, and then plan further.
Ma'am, I'd like to add.
Madam Shagufta Tahir, would you like to add anything? Do you follow the same regime, or do you have any different pattern in Pakistan? Would you like to add?
Please unmute, ma'am. Please unmute, ma'am.
Actually, we actually keep the patient after the birth of the baby. That is the stage 4. Until unless the patient passes the urine, we do not shift the patient in the ward. Because most of the time, the patient go into the postnatal retention of the urine. So I had a study on it. One of the residents, she conducted, did the research, and she has got a research article on it. So it's a very important part of the postnatal and obstetric care. that one should be careful for the bladder later on. Another thing what I want to add is the catheterization. It is also a surgical procedure, and it should be performed under proper sterile conditions, because when we catheterize the patient, it is the chance when we can introduce the infection. Definitely we need to put during the before the surgery if we are doing the cesarean section, but it must be done in a sterile condition so that we should not introduce infection. So this is what I always take care of my patient. So the catheterization should be done in a theater and with all measures available and non-touch technique, so that we should not have the postpartum UTI to the patients as well.
Hello, Vijaya.
Ma'am, I'd like.
Hello.
Ma'am.
Yes, ma'am.
Vijaya, she is, I mean, having a very high load of obstetrics,
Yes,
deliveries, and management. Would you like to contribute anything, say a few words, Vijaya, about your experience with the postnatal voiding problems in women?
Yes, ma'am. Because of in Institute of Obstetrics and Gynecology, we had quite a number of deliveries. But then after section, we used to keep the catheter for 2 days, ma'am. The removing for 24 hours is, we are not practicing as of now because of the patient's non-cooperation, and they feel comfortable once they start taking something, and maybe we should start practicing removing at 24 hours. That's what we do at private practice. We remove after 12 hours, ma'am. But then in government setup, it's not able to practice that part. Madam, your comments on that, ma'am? Raji, ma'am?
Yes, it is. I think your institutional protocol, because your workload is so huge, and so many deliveries, and it's always understaffed, and you need to have your own protocol. I think each one is justified in planning what is acceptable to their own condition. I think I totally agree with you, Vijaya.
Yes,
Sita, would you like to add anything, Sita? Sita Lakshmi? Sita?
Please unmute, ma'am. Please unmute.
Sita, unmute and can you hear me?
Yeah.
Am I audible?
Yes,
Yes, ma'am. Yes, ma'am.
Most of the times in our institution, because of the perineal pain following episiotomy and other perineal lacerations, and 50% of the patients have postpartum voiding dysfunction. Once the analgesics and the constipations are relieved, many of the patients get better with the voiding problem. So all the patients should give importance in the period, in the immediate postpartum period, about the episiotomy wound pain care and the constipation. Encourages the patient to take plenty of fluids and proper educating the patients to void at regular intervals.
Gauri, would you like to add anything? What is your protocol in JIPMER?
Yes, madam. We also follow the same protocol of after cesarean section. We keep it for about at least 12 hours, depending on the situation. By and large, next day morning, irrespective of, because of the second stage prolongation. And so in these patients, we always check the post-void residual urine, because there may be a lot of times it may be overflow incontinence. A lot of times the patient might have voided, but the bladder may still be full, and we think that they have voided complete, which is probably the reason for
internet problem.
Subsequent infection and other problems on a voiding plan.
Yeah, connection is weak.
Your connection is weak, actually.
Mr. Shankar, I take it that all good things should come to an end. I think it is a hint from you that we have exceeded the time limits. I thank each and every. Is Meena there for her vote of thanks?
Yes, ma'am. Am I audible, ma'am?
Yes. Please go ahead, Meena.
Ma'am, it's a great privilege, as madam has already told. All the best programs have to come to an end, and it's my privilege to thank the doyen, the first Asian urogynecologist, Dr. N. Rajamaheshri madam, the president of URPSSI, along with Courts India, Nagashankar, to have given this excellent webinar in UTI in women with myths and mysteries to bring all the faculties from different continents. Like I would like to thank all the chairpersons, Dr. Arun Chawla from Manipal, Dr. Chengal Ryan, Dr. Neeta Thakre from Ahmedabad, Dr. Saiba Akhtar from Bangladesh, Dr. Shah Gupta from Pakistan, Dr. Poonam Mathur from Indore, and also like to thank Dr. Gauri Durarajan from Pondicherry, Dr. Ankur Mittal from Rishikesh, Dr. Hemant Koel from Delhi, Dr. Jay Ganesh sir from Chennai, and also to thank all the faculties who have taken their time in talking about UTI and pregnancy, the chairperson, Professor Vijaya ma'am from IOG, Ramani Devi ma'am from Trichy, Shyama Kanuga ma'am from Odisha, Umarani Swain ma'am from Delhi, and Mohan Chandra Regmi from Nepal, Subhash Chandra Biswas from Kolkata, and JB Sharma sir from Delhi, Sita ma'am from IOG, Meera Raghavan ma'am from Chennai, Aparna Hegde from Delhi, Lily Verghese ma'am from PMC Vellore, Shrikala ma'am from KGH Chennai, Amita Jain ma'am from Delhi, and also my close friends, Dr. Narmada and Dr. Jasima for having coordinated the session. And thanks for the opportunity, and it was an excellent learning. Thanks to Professor Rajamahesh madam. Thank you, ma'am.
Thank you, panelists, participants, chairpersons, Force India, and all the registrants, participants, and delegates. Thank you.
Madam,
Look forward to seeing you all in future.
Madam, on behalf of all
enjoyed,
faculty,
ma'am. Thank you so much.
Thank you.
Thank you.
All the delegates, and thank Almighty for having given this excellent timing as well. Thank you.
Thank you.
Thank you.
Thank you, madam.
Thank you, madam.
Thank you.